Good morning. My name is Ferit Garagozlu. I am the president of the Society of Robotic Surgery, and on behalf of our executive director, Dr. Vip Patel, and the society, I'd like to welcome you to the first of what will be a series of Sunday sessions. These are going to be in different specialties. We're starting with thoracic surgery and a discussion about hiatal defects and some of the new role of the robot in the treatment of this disease. Welcome to our Sunday sessions. We can start the slides, please. Robotic surgery has been around now almost 20 years. I've had the privilege of being involved with this exciting field in surgery for the whole time. We're entering a different era in robotic surgery. We had robotic surgery 1.0, which was really designed to bring greater precision to minimally invasive surgery. We've done that. People like Patel and Giulianotti and some giants in the field have truly paved the way to applying that to various otherwise laparoscopic procedures. In the next phase, robotic surgery 2.0, will allow us to see and understand disease more clearly. We're able to see disease in situ. It'll erase the artificial boundaries of specialization, which are based on this regional anatomy of diaphragms and separating abdominal surgery from thoracic surgery, for example. And it'll contemplate crossing these boundaries, which are historically defined by traditional open surgery. This morning, we're going to talk about the first of these truly frontiers in the world of surgery, and that's dealing with hiatal hernias. Most people think they know about hiatal hernias, but I hope that after our discussion today, they will find out that there is more to the story than they thought. This morning, we have a panel of experts. I have the privilege of working with all of them, and as you can see, and we will see them through the morning, we're going to talk about the diagnosis and workup with Dr. Atikos Zaman, and then our other colleagues are going to talk about the complications in terms of pulmonary and cardiovascular issues. We will talk about the surgical approach. We're going to talk about the postoperative management of these patients, which is very, very important. The logistics, the dance in the operating room will be discussed, the design of the hospital program, and finally, we're going to talk about the role of robotics for redo surgery, which is very, very important. Should we even talk about robotics and redo surgery? So as you see, this is a very busy morning, but it is going to be a very valuable addition to most of our knowledge base. We're going to start talking about robotic laparoscopic thoracic surgery. Like everything else, when you go to the moon, you don't go right to the moon. You start with the Gemini, the Mercury, and slowly work your way to Apollo and the moon. And this is what our vision is, that we will do laparoscopic robotic lung surgery and chest surgery because it's safer and better for our patients very soon. But the way to do it is start with things that move from the abdomen into the chest, and this is why we're talking about transhiatal mediastinal surgery for hiatal hernias today. So, it is important to understand where we have been. You cannot go forward without knowing where you have been and your history. And this is my job for the first session. This is a picture from a textbook. You can throw this out in the garbage. This is not what it looks like in person. If you look at the hiatus, as you see in here, the crura of the diaphragm are not in the same level. So if you think that's what the anatomy is, you're going to do the wrong surgery. So again, it is important to understand that a lot of the historic information is the product of its time. This is what we have tried to use as a way of classifying hiatal hernias. This dates to in the 1920s, and it is useless and it is irrelevant to what we do. And hopefully at the end of our discussion, you'll see that there are different ways of looking at this from a functional standpoint. The reason we've picked a hiatal disease to talk about is that it is like 6 blind men who are out to discover the nature of an elephant. The blind men are the gastroenterologists, with all due respect, the pulmonologist, the cardiologist, the ENT specialist, the hematologist, and the surgeon. They are missing the whole picture because they're involved in pieces of this elephant. So let's get to look at the elephant from above. And finally, it is very important in medicine to understand that you see what you know until you look. And the robot, unlike what most people think, is giving us new vistas to understanding disease, giving us new set of eyes. I'm going to talk about the history of hiatal disease, which is really crucial to the further discussions. We will talk about the fact that when we discovered hiatal defects, this was in the era when surgery was all about hernias. In fact, it's interesting, and my alma mater at the Halstead surgical program, a person would be advanced based on the recurrences of their inguinal hernia repairs. So in the early part of the 20th century, it was all about the inguinal hernia, and we saw hiatal hernia just as another hole that needed to be treated like a hole, classified like a hole, fixed like a hole, and we fell flat on our face in the mid part of the 20th century when the results were terrible. Then, which is human nature, when we found that it was bad, then we went into the era really where we threw the baby out with the bathwater, forgot about the hiatus, and started talking about reflux. This is beginning with in the 1950s with the Nissen procedure and so forth. So everything is all about what kind of fundoplication, it's over. Well, I think most people would agree that once again we have fallen flat on our face because we are not looking at the elephant. We're looking at the pieces of this elephant. And the robot has helped us do that. So now we're in an enlightened period of understanding that this is obstructive disease, and it's an anatomic defect. The anatomic and the functional components have to be treated at the same time, and we're also understanding that heartburn or GERD, which is terribly used and too widely used in these patients, is probably esophagitis caused by organ failure. We have forgotten about the organ. It's fascinating. I'll use an analogy. In cardiac surgery, when we were interested in reflux of one of the cardiac valves, like an aortic valve insufficiency, when I was a fellow, we would wait until the patient had heart failure before we replaced the valve. And that was because our valves had a finite life. Then we discovered that it doesn't matter what you do with the valve as if the organ fails, because the organ failed. And this is the same story. We need to concentrate on the esophagus rather than the GE junction, rather than reflux, rather than all these things. Once the organ fails, it doesn't matter what you're doing. That's a very important point. So let's talk about the era of anatomic repair. I won't go through all this, but as you can see, it's 500 years ago that we discovered hiatal defects. We saw them on X-ray first in the beginning of the 20th century. People like Serosi and others treated it like a hole, like any hernia. And the question was, what's the size? I still hear this today. It's amazing that 100 years later, what size of a hiatal hernia should be treated surgically? Should be chest, abdomen? What type of hiatal hernia? The typing that I showed you is from a paper from 1926. We have not done anything that we used to do in 1926 in medicine, and here it is. We're using this information every day. So time for really looking at it differently. This slide shows you the many things that were done by surgeons who meant well, but treated it like a hole. So it's interesting, in inguinal hernia surgery, you do these relaxing incisions to get things to come together in a very simplistic way. So they did the same thing over the years, relaxing procedures. They would crush the phrenic nerve so the diaphragm could come together easier. As soon as the guy could, then he couldn't breathe anymore, but maybe his hiatus stayed together. And then fascia lata was used to close it, just like we do mesh. Please, this is not a hole, trying to put stuff to plug the hole. And really, Allison is a surgeon from England who gets a lot of credit for understanding that the anatomic repair didn't work because they didn't understand the physiology. In fact, for those who are interested, Allison coined the term Barrett's. He worked with Dr. Barrett. Dr. Barrett didn't coin the term Barrett. And they first described Barrett's esophagus. But the key is, in 1973, at the American Surgical Association, Allison did a mea culpa. He basically said, everything I did in my career, 421 patients over 22 years, look at the numbers, by the way, for some of our audience to see the kind of experience we have. 22 years, 400 patients he had. Failure, 50%. That's like flipping a coin. So that is not an operation that works. The functional repair is a fascinating story, so bear with me as we go through this. Rudolf Nissen, fascinating man. He was a product of the highest order of the German School of Surgery, worked with Sauerbach in Munich, very famous people. First person to do a pneumonectomy. He was of Jewish heritage, so he had to get out of Germany in the 1930s. He was a professor of surgery in Istanbul, Turkey. When he was there, in 1936, a 28-year-old man comes with a distal esophageal penetrating ulcer. And he resects that, and then he basically does, quote unquote, the Nissen fundoplication because he needs to cover up that esophagus. And that's it. The guy survives, things just move on, Nissen moves on, and he's working on various things about reflux that are not working, like gastropexies, and so forth. And he goes back to Switzerland after the war to be professor of surgery in Basel. And when he's there, the young man comes to see him. And Nissen is expecting to see wide open reflux because he disrupted everything, and he sees no reflux. That's the science behind the Nissen fundoplication. End of the story. Anecdotal view. So then he takes a 49-year-old woman with reflux. He does a posterior 360 fundoplication, which bears his name, published in 1956. And for the next 50 years, we have tried to shove this round thing into a square hole, or whatever you want to call it, trying to understand and make excuses about the fact that this surgery is appropriate. And people have made it smaller, lesser, 2 centimeter, 4 centimeter, on and on and on. But really, it's like putting a lipstick on a pig. It's still a pig. And that's the issue that we're dealing with. So, not to be graphic. Now, so the issue is, what's wrong with the Nissen? Really, it's because it was based on the understanding of the 50s that there is a sphincter. In 1956, same time as Nissen was working, at the Mayo Clinic, they did the first manometry studies that showed a high-pressure zone at the GE junction. Because there was a high-pressure zone in the neck with the cricopharyngeus, they said, this must be the lower esophageal sphincter because there is an upper esophageal sphincter. And when I was a medical student, actually, I spent a year dissecting GE junctions looking for this sphincter. And there is no such thing as a sphincter at the GE junction because it's a functional obstruction. This is not a sphincter. And people have come to understand that there is no sphincter. And so hopefully after today, no one will call the GE junction a sphincter. So if you're going to make a sphincter where there's no sphincter, it's not going to work. There is a gastroesophageal valve, and we have over the years studied, the valve, and we've tried to understand, thank you very much. See, talking about Nissen gets me all upset. Thank you very much. So the people from England have worked hard on this problem. This is Mr. Belzy. By the way, in England, surgeons are Mr. And Mr. Belzy, who is really contemporary of Nissen, worked on the concept that there must be something other than a sphincter. So he, and I won't go through it, but years of research that basically culminated with a valve. This is a picture of the Belzy fundoplication, which is making a valve by pushing the esophagus into the stomach. So Mr. Belzy, back in the 50s, 60s, and early 70s, was really the person who started this process where we understood what's going on. And The problem with the Bell-Z fundoplication was that it required to open the chest. And very few people were interested in that. And then as soon as this information started to get disseminated, laparoscopy came, and you can't do a Bell-Z by laparoscopy. Nissen is easy to do with laparoscopy, so you can see how a lot of the socioeconomic issues and other things sort of took over, and we went on with that. But there's a lot of good work about the valve, the gastroesophageal valve. This is back from the 1980s, where the reappraisal of the flap valve. It's amazing to me that now, 40 years, 50 years later, we're still talking about sphincters. This is a study from Hill looking at the valve, and he actually graded the valve that you can see on endoscopy if you retroflex and look at the GE junction, and you can use that grading for surgical repair. This is from our work from 1998, where we described a laboratory model for looking at the gastroesophageal junction and looking at the various surgical procedures. And we did a cadaver study looking at the valve back in 1998. So the concept of the gastroesophageal valve is set in stone. There is a valve, and this is very important. So in summary, what's going on historically is we are now at a point where we understand the anti-reflux barrier to be the intussusception of the esophagus into the stomach by 2 centimeters, forming a flap valve that goes about 270 degrees of the 360. And this valve is suspended onto the hiatus. This is where the GE valve and the hiatus go hand in glove. And those two things are very important. You can't just have one without the other, as they say. And the analogy is like a door on a frame. You can have any door you like, but if the frame is bent, that door is not going to work, and which is the hiatus. And then we have spent the last 50 years talking about what kind of wood we should put in this door, which has had a crooked frame. And that's really, should you do a Nissen? Should you do this fundoplication, partial, full, etc.? It doesn't matter. If the two don't go together, it's not going to work. So in fact, one of the biggest problems with fundoplications is that they are not suspended onto a hiatal reconstruction, and they fail. And it's a very interesting thing that nature does not do 50 different ways. If you look at the mitral valve, our history of understanding mitral valve physiology has come from fixing the valve, right, without fixing the annulus and finding out that that doesn't work, or taking the valve out and putting a valve in there, finding out that doesn't work. And the function, and all the Cordy and all the people who understand mitral disease know that it is a combination of the valve leaflets onto the annulus of the valve that makes it work. And that's really the similar thing to the GE junction. So forget about these kinds of ideas. Let's go back to where the hiatus fits into this. So frankly, this classification is useless. I want to point out one other thing. Every physician I see who is not in this field will talk about a sliding hiatal hernia like it's sliding up and down. Now, I just told you that this classification of hiatal hernias dates back to 1926. In 1926, the surgeons found out that when they were fixing inguinal hernias, they were all horses, but there was a zebra inguinal hernia, where if they went to take out the whole sac and shove the bowel back in and fix the hole, they ended up taking half the cecum with the sac. So they called that inguinal hernia, which was one in like 8,000 cases, a sliding inguinal hernia, meaning the peritoneum slid like a mudslide, slid, and there is no sac because the cecum is sitting in there, and you're not going to push the cecum back in because it's slid in there. It needs to be separated, then reposition. All hiatal defects, because the back of it is the esophagus, is a sliding hiatal hernia. So type 1 is not the only one that's a sliding hiatal hernia. All hiatal hernias, by definition, are sliding hiatal hernias, something that has gotten lost in translation over the years. And if you understand that, then you cannot treat this like a hole. You have to free up that esophagus, like that cecum, and everything has to be put where it needs to be. not just plug up the hole. And now you can see why the surgeries have failed. So this is a picture of a sliding inguinal hernia. You can see the cecum. That surgeon had a really bad time if he treated this one like a regular inguinal hernia. And if you turn that around and make the cecum the esophagus and so forth, you can see that that's why we call this a sliding hernia. So, and this is not new information. It's just, again, getting lost in translation is like playing the telephone game, you know? It just gets worse and worse. So basically, the issue is that all sliding hernias need to be repaired. It's all about the esophagus, not the hole. And this has been known since the 1990s. What's the relationship of hiatal hernias to GERD? Well, we have done a lot of studies, but the bottom line is I'm going to give you a kind of a overall view. The hiatus, the esophagus comes, it's intussuscepted. It is suspended onto the hiatus. The hiatus stretches. If it stretches to 2 centimeters, which is not visible by endoscopy, the valve, which is connected to the hiatus, comes out of the stomach, and you end up with no valve, so you get gastroesophageal reflux. As soon as you see a hiatal defect, then that means that the stomach is starting to move into the chest. Then you enter a phase of obstructive disease rather than reflux disease, because when the stomach comes up, it's sort of like a mini Nissen. You know, so the bottom line is you have to understand that this is a spectrum of disease. This is not just in specific things. The other issue is, and Dr. Alabi will be talking about this a lot today, the hiatus, this is a picture of the Champs-Élysées coming to the Arc de Triomphe. This is Paris. The hiatus area is the Arc de Triomphe. When there's something wrong with the hiatus, it starts to affect all those streets that are coming in. So the hiatus affects the esophagus, it affects the GI, the heart, it affects so many things that are in that location. It's sort of the center of the universe of the body. And the patient's symptoms are related to all those other things, which unfortunately, because these patients have been put through the system by GI referrals, they're not understood by most people. So the present understanding of hiatal defects and typing is as follows. Type 1 are hiatal hernias less than about 2 to 3 centimeters. We still have to kind of figure that out, where exactly that is. Those patients have GERD, and most likely those patients should not have surgery. Surgery has failed as an anti-reflux type of a thing. So those patients probably need something other than surgery. And if you're going to operate on those patients, you're going to have problems in a lot of them, and everybody's experience is that. Type 2s are those greater than 3 centimeters, and those patients have esophageal obstruction. They have heartburn symptoms not from GERD, but from the fact that they have basically the esophagus is diseased. They have cardiac disease. They have shortness of breath due to decrease in preload, and ulcerations and bleeding and so forth, and our colleagues will talk about that. So to think about these two types allows surgeons to make the right decision. Apples and oranges. And really, the patients, we think that everything is a horse. These are the zebras. These are the complicated things. So, pathophysiology of hiatal defects is historically, now you see that it is a question of obstruction. The heartburn is really esophagitis rather than acid reflux, compression of atrium and so forth. The gastroenterologists are only looking at a piece of that elephant, not the whole elephant, and it needs cardiologists, pulmonologists, esophagologists, and a surgeon, and really also medical specialists, also hematologists, because there are so many patients getting iron infusion with their huge hiatal hernias as they're bleeding from their Cameron's ulcers. And we need to be thinking about an anatomic and a physiologic repair for these patients. So now we are back to the future, to the era of anatomic and functional repair. Thank you for allowing me to present this morning. We will be discussing this further as some questions come about. I'm going to move on and introduce you to a colleague who humbles me every time I talk to him because he's truly an esophagologist of the highest order. Dr. Atiq Osman is on the faculty of the University of Florida, Central Florida, I should say. He's the director of the Heartburn Center at the Digestive and Liver Center of Florida. It is with great privilege that I introduce Dr. Atiq.
Thank you, Dr. Farid Garagozlu, our esteemed colleague, and I would say one-of-a-kind, amazing surgeon who make a big differences of our patient with hiatal hernia, especially giant hiatal hernia. So from a gastroenterologist perspective, hernia is I would say, a very simple thing, but it's not a very simple thing. The way we gastroenterologists perceive a hernia, or hiatal hernia, or giant hiatal hernia, is very different the way a esophagologist think about it. The way Dr. Garagozlu say, esophagologist, that means I'm a gastroenterologist with a special concentration on the esophagus. And when it comes to giant hiatal hernia, you heard that it's just not a simple hernia. And also you heard that the concept of lower esophageal sphincter is not really a sphincter, rather than a valve, rather than a functional gateway. And that's why it's very important to think about the anatomy, think about physiological perspective, and then help the surgeon for the treatment. Now, if I would like to talk about diagnosis and the workup of giant hiatal hernia, we have to know a little bit of anatomy, also the physiological function test. I would like to present a small case to you, which I very frequently see in our office. This is a 64-year-old Caucasian male presented with progressive dysphagia and cough. One of the important things about hiatal hernia, we always incidentally find giant hiatal hernia. We don't get a case that this is a hernia you need to diagnose. Maybe the patient went for a barium swallow or upper GI series, or just come just like this patient, progressive dysphagia, cough, and then we incidentally find it. So this gentleman has gastroesophageal reflux disease. That's why all we define for 30 years, hypertension and gout. No other significant medical history. But he has very interesting history. He has recurrent sinusitis. He has upper respiratory infection for last 3 years. His BMI is high, is 36. Obstructive sleep apnea, diagnosed 2 years ago. And this patient also has recurrent chest pain and has workup done in the hospital recently, and there's no acute cardiac problem was found. So this is a patient who presented to us with progressive dysphagia. Obviously, one of the first tests would like to see the anatomical problem in the esophagus. Obviously, we recommend an endoscopy. And here is the picture of this patient with endoscopy. You can see there is a giant hiatal hernia. And you can see the normal endoscopic view. You can also see the retroflex view. And when you look at this picture, you see here the phrenicocardiac angle. As a gastroenterologist, a lot of us was never really think about considering that. But when you work closely with a surgeon, when you look at the pathophysiology, when you look at the surgical history, which Dr. Garagozlu very eloquently discussed, how it comes to nascent fundoplication to today's surgery, why it is important. And you look at the barium study, and you can see phrenicocardiac angle and so-called gastroesophageal junction, and this big hernia is in the chest cavity. So obviously, he was diagnosed with a giant hiatal hernia. And my responsibility is to talk today about diagnosis and workup. If I want to diagnose a hiatal hernia, when a hiatal hernia happens, what Dr. Garagoslu was telling, it doesn't happen in one day. Some people born with a hiatal hernia. But to develop a giant hiatal hernia, yes, some baby born with a huge hiatal hernia, but majority patient we see, it happens slowly. And it happens like a sliding hernia, which we traditionally said type 1 hernia, eventually go to type 2, type 3, and eventually type 4, which is a huge, humongous hiatal hernia. So if we talk a little bit about the anatomy, this is very important from a diagnosis point of view when you have a tubular esophagus, and we talk about typical A ring and the B ring. And B ring is basically nothing but the Z line, which we think about when you think about A ring to B ring, that's what the esophageal vestibule. And from the B ring, when you come to the diaphragm, right above the rugal fold, that is very important because that's why the phrenic ampulla is located right from the rugal fold to all the way to the A ring. And that's very important because this will define the function of the gastroesophageal junction or function of the valve we are talking about. And how much is displaced and what displaced with that will define this patient's mode of future surgery or what you're going to do with this patient. So if we think about the anatomy, we talk about type 1, type 2, and type 3. But what is important, if you look at the first picture, which is a normal esophagus and the stomach, you see phrenicoesophageal membrane is very important when it comes for the integrity of the esophagus, especially which is in the lower part of the thoracic cavity. It's important to think about this fascia, which is in the chest cavity, the fascia in the abdominal cavity. We need to think about the diaphragm. Why? Because whenever a type 1 sliding hernia happens, you see how disruption happens with a couple of things. Phrenicoesophageal membrane, which is disrupted. The fascia in the thoracic side as well as the abdominal side also disrupted. The nerve supply also get disrupted. And I give a very simple analogy. Just think about this. If this is the esophagus, and this is the lower esophageal junction, look, with every slice of the hernia, it goes up and down. And when it goes up and down, a lot of things happen. It affects the integrity of the muscle, integrity of the fascia, which is coming, also integrity of the nerves. And that's why not only the anatomy change, also the function of the esophagus changes. And that's why we see the failure of a lot of hiatal hernia surgery. And that's what you need to think, that just cutting the hernia is not enough. You really have to think about restructuring the esophagus and the stomach, basically correcting the anatomy. And that's what's very important. And this concept is very, very important. This was very well studied in Oxford University. Why a sliding hernia when it becomes a giant hernia, what you really need to know. And this three-dimensional graph shows something very nicely. It shows the relationship between the hiatal hernia size, lower esophageal sphincter pressure, and the reflux score. As you can see, when there's no hernia, you have a good LES pressure. When the hernia size is barely 2 centimeters, you can see significant reduction of lower esophageal sphincter. As it grows bigger to a huge giant hernia, you can see it's not type 1 anymore. It's type 4. Virtually have no LES pressure. And another important thing beside the Elias pressure, this patient's reflux score can be significantly high, or patient lost the sensation of the reflux, and also with the distensibility of the esophagus, the patient developed dysphagia. Good number of patients develop dysphagia, and why they develop dysphagia? That's a very interesting question, and I go for the same analogy again. If I say that this is the esophagus, and if we just keep on pulling, imagine if we pull my coat 1,000 times a day, it will not be very effective anymore. And one of the most important things happen with the formation of the hernia. You have to think about the esophagus, because esophagus lose the distensibility. Esophagus, the nerve, almost shattered. So these patients develop very significant low motility or almost a peristaltic esophagus. And this is something you really have to consider when you do the workup for giant hiatal hernia, because you are going to face these things of dysphagia, not before the surgery, also after the surgery. And that's why what surgery you're going to choose is very important. The failure of the surgery obviously is not the preoperative or paraoperative period, is 6 months, 1 year after the surgery. And we have seen from the big studies why Nissen fundoplication is not the best surgery. So another things I would like to talk about, the giant hiatal hernia, which is type 2, 3, and 4, paraesophageal hernia. It is associated with abnormal laxity of the gastrosplenic and gastrocolic ligament, which normally prevent the displacement of the stomach. And as the hernia enlarge, you see the greater curvature of the stomach roll up to the thorax. And because the stomach is fixed in the GE junction, the herniated stomach tends to rotate around its longitudinal axis, resulting an organoaxial volvulus. This is what I'm talking about, how a organoaxial volvulus is formed. And over the time, the entire stomach eventually herniates. And with the pylorus juxtaposed to the gastric cardia, forming an upside-down intrathoracic stomach. And this is the biggest challenge we are talking about. This is the biggest challenge because we have to correct these anatomical problems, what is happening. And that's what an important part of the diagnosis and the workup of the hiatal hernia. So this is a beautiful three-dimensional picture. When you compare, when I do an endoscopy of different kind of hiatal hernia patients in different stages, when I go in the stomach, one of the most important things is to do a very close lookup of the cardia, of the GE junction, look at the gastrocardia angle, which define is this patient is a simple type 1 versus type 2, 3, or 4. And you can see in type 1, where the normal ridge of the tissue approximate closely to the scope. But when you look at type 2, the ridge is slightly less well-defined. And when you look at type 3, the ridge is affected, and the hiatus is patulous. But when you think about a really giant hiatal hernia, the hiatus is wide open at all time. Initially, when I look at the respiration, I see this obliterate in the phases of respiration. Here, here, and here is usually always patulous. And that's important when you think about the pathophysiology of this giant hiatal hernia. So what is the key clinical feature? Because you understand that we don't really see a patient to diagnose a hiatal hernia. Most of the time, hiatal hernia is an incidental finding. And that's why they send to us. A good surgeon sent to us because they want much more information, not only the anatomy, but the functional perspective of the hiatal hernia. So endoscopic and radiological studies suggest 50 to 94% of the patient with reflux have a type 1 hiatal hernia as compared to 13 to 59% of normal patient. So good number of normal patient has type 1 hiatal hernia, and that eventually develop type 2, type 3, and type 4, eventually a huge sliding hernia or giant hiatal hernia. The likelihood of symptomatic reflux symptoms increases the size of the hiatal hernia. Maybe you are talking about type 2. And then when the patient with type 1 hernia have prolongation in acid clearance, especially with the recumbent position, that's the time we see the early physiological changes happening in the distal esophagus. And hiatal hernia compromise the fluid emptying from the distal esophagus by re-reflux from the hernia compartmenting during the swallowing. And that's why the patient develop the chest, lower chest tightness. And that's basically eventually predominant symptoms of our giant hiatal hernia patients. They don't have significant reflux symptoms because what happened, development of the hiatal hernia disrupt the nerve, disrupt the normal esophageal innervation, disrupt the normal musculature, and symptoms change to different type of symptoms. And I will talk about it. Our pulmonary colleagues, who will be talking today, Dr. Alabi, I see many patients from him who basically presented to him as pulmonary fibrosis, or who presented to him as recurrent upper respiratory infection as a consequence of this huge giant hiatal hernia. And patient does not have significant reflux symptoms, is wide open, bile is traveling all the way to the esophagus, going to the airway, going to the sinuses, causing continuous problem. And those are the anatomical consideration as a pathway to developing of a giant hiatal hernia. Now, as I see, the most common symptoms, because we're talking about symptomatology, it's help us to diagnose it, is substernal pain or postprandial fullness, nausea, retching, and GERD symptoms is less prevalent as compared with the patient with type 1 diabetes, type 1 GERD patient or hiatal hernia patient. So this is important. Now, what are the most common complications we see with the giant hiatal hernia? And that's how the patient come to us. Gastric volvulus can cause dysphagia, while postprandial pain is usually related to gastric distension. Bleeding is not very uncommon, but occurs from gastric ulceration with continuous friction. We see erosions, which we call Cameron ulcer, and that is a definitive diagnosis, a definitive indication for the patient to go for surgical management. Also, rarely we see incarcerated hernia pouch. Now, respiratory complications, I just told you, upper respiratory problems, recurrent aspiration, recurrent pneumonia, pulmonary fibrosis, chronic sinusitis, these are also very common. So if we think about the typical and atypical presentation, as a clinician, you always have to think about, when you think about the diagnosis, they can have dysphagia, they can have dental erosions, they can have sinusitis, asthma, aspiration pneumonia, silent aspiration syndrome. I'm pretty sure our pulmonary colleagues see it very often. And those who are very smart, they always like to make sure this patient does not have significant functional issue of the esophagus or anatomical problem like a giant hiatal hernia. Pulmonary fibrosis, and rarely cardiac arrhythmia. Now, when you think about diagnosing, radiological findings are very important. And as I told you, most of the time, the primary care doctors or surgeons or pulmonologists or even allergy immunology doctor, they incidentally find this huge hernia. It can be done by just simple upright radiograph, sometimes computer tomography, sometimes MRI. And these are some of the pictures we see very often, like this one, where you can see the big hernia is staying right there. You can see it's pushing the heart, obviously push the lung cavity, reducing the effective space for the lung. And if you do a barium swallow, you can see that the upper GI series shows this big hiatal hernia. And when you do a CT scan, you can also see that. And see how notorious they are. They slowly push the heart, obviously push the lung, reduce the effective lung capacity. So when you are clinically suspicious about hiatal hernia, it's very important because patient come not necessarily a typical hiatal hernia symptoms. Obviously, reflux, heartburn, regurgitation, and dysphagia. Regurgitation and the dysphagia is the most common giant hiatal hernia symptoms. And that prompts us to do rapid workup, endoscopy, or other functional studies. And also, giant hiatal hernia is suspected in patients with a history of surgical dissection of the hiatus. Like the patient has anti-reflux procedure, or esophagomyotomy, or partial gastrectomy, and epigastric of substernal pain or fullness, nausea, or vomiting. And as I told you, the hiatal hernia not a diagnosis that is pursued in and of itself, and is usually diagnosed incidentally on upper endoscopy, manometry, or other imaging study. And I'm telling it again and again because most of the time the patient has not significant typical symptoms with giant hiatal hernia. They present completely differently than your typical reflux. So how we diagnose? So the patient we saw, the first thing we did is upper endoscopy. But sometimes we combine the upper endoscopy with a barium swallow to look at the functional dynamics to give some more information to the surgeons. And in fact, surgeons do most upper GI series than us. We depend more on endoscopic evaluation, and we have a wonderful tool called manometric study with impedance. Is really replacing a lot of tests to give us much more information of the management or when we do the workup for the patient for giant hiatal hernia repair. So obviously, the endoscopically you can see, I just told you that this is a type 3 hiatal hernia. You look at the radiograph, you can see the part of the stomach is going to the chest cavity. The same picture again, you see the huge portion, and you can see also the change of the axis, advanced giant hiatal hernia. So what are you going to do when I do diagnose a big giant hiatal hernia? I definitely would like to do a high-resolution manometry. Because what we are talking about, the change of the dynamics, change of the function, we are talking about a valve. We are talking about a valve. We are talking about the change of the anatomy. You have to always think about it. It's just not simply fundoplication we are talking about. We have to think about the diaphragm. We have to think about the crura. We have to think about the membrane coming from two different perspectives, from the thorax as well as from the abdomen. You need to correct all those. And then also you have to think about what are the changes happen during the development of this giant hiatal hernia. It has to be a holistic approach. You just can't. It's just not blocks of bricks that you just fix it. You have to think about the anatomical changes happen over the time. You have to think about hyperalgesia. You have to think about the so-called leaky esophageal wall. You can think about the teared esophageal muscle. And that's why this high-resolution manometry is very important. And if we can combine the esophageal pressure topography with that, EPT, it is very important because it can tell us a lot about the crural diaphragm and the lower esophageal sphincter pressure. Unlike conventional manometry, when you combine the high-resolution manometry and EPT, it can reliably identify a sliding hiatal hernia as it permits real-time localization of the GE junction component without a typical swallow or distension-related artifact. And that is very common. That is very common when you do an upper GI series. So this is a picture of a typical ERM, where we analyze high-resolution manometry, but we also would like to see lower esophageal sphincter and crural-diaphragmatic matrix together. And when you do the test, when my technician do the test, it's very easy for us nowadays just to use a very special computer software technique to diagnose the HRM through the HRM LES CD matrix. And it really helped us to find out not only detecting the giant hiatal hernia, but also to predict how and what kind of surgery can be helpful to these patients. And that's why when I see a big hiatal hernia and combine this test, it tells us if these patients really get benefited from robotic valvoplasty or not. I never think about sending any giant hiatal hernia for Nielsen fund implication because, as I was mentioning, that the pathophysiology of hiatal hernia, you have to think quite a bit of different component rather than just work on the fundus or cardia. So you have to have a total approach rather than a very simple approach. As Dr. Garagozlu was telling, that we have to think about the whole elephant. You just can't think about the one leg or one tail. You have to think about the whole thing. And this is what is very, very important. I do a HRM, and this is what I find out. This patient has esophageal aperistalsis because the chronic pulling and pushing the esophagus make these changes in the esophagus where the esophageal sphincter, yes, it is very tight, but the body of the whole esophagus, as you can see, there is no change of colors. It's like an ocean, blue ocean. It looks good, but it's not feel good. The patient has dysphagia because of that. Not the huge hiatal hernial sac causes a lot of anatomical and physiological issue, but the esophagus over the time doesn't work. And these are the patients you really have to think about it. This is a body's defense mechanism because you have this wide open hernia. So the esophagus kind of obstruct your food not to go right away to that. So that's the physiological analogy, not practical thing. But you have to think about this. And if this patient has esophageal aperistalsis and you do a robotic valvoplasty, you have to be ready that this patient will have significant dysphagia and have to think about the different kind of approach of surgery of these patients. And that's why a surgeon who don't know the anatomy very well, the size, the cruroddiaphragmatic angle, and also ERM study from a very experienced gastroenterologist, I think they commit a big mistake just to do a surgery to these patients. When it comes to treat a giant hiatal hernia, it's a team approach. It's a total team approach, and it's a very, I would say it's a very holistic approach when you combine an esophagologist who don't only just do an endoscopy and say it's a small hiatal hernia, it's a motor side hiatal hernia, rather than do a complete study and understand what are the physiological changes happening in this patient and think about post-operative perspective, what are the complications this patient is going to face. That is very, very important. And these patients who has giant hiatal hernia with esophageal aperistalsis, these patients likely have different sets of post-surgical implications, symptomatology, which we need to address before the patients go for the surgery. So after the surgery, the patient come and tell, doctor, you did my surgery, but I have new problems, and your surgery is a failure. And that's why it's very important to discuss pathophysiology, take longer time to discuss the patient, what is the implication of your surgery. And that's how important part of our diagnosis and workup. When we talk about diagnosis and workup for the surgery, workup for the post-surgical complication or physiological changes of the patients we need to talk about. And this is another area where you also ignore quite a bit. Delayed esophageal emptying as well as delayed gastric emptying with change of esophageal motility. We need to think about it. And yes, some surgeons that do think about it. They do pre-surgical gastric emptying study to show the patient, look, your esophageal, your gastric motility is impaired. But you have to understand one big thing. With a giant hiatal hernia, disruption of your fascia, disruption of your muscle, disruption of your nerve, and also a majority of your stomach in the chest cavity, obviously they don't have the real functional motility of the stomach, and this patient has impaired gastric emptying study. You need to talk about it, that these things might not improve, or these things might improve slowly. Post-surgery, you will have no significant symptoms of many things, and you might develop significant symptoms of gastric emptying. You have to counsel this patient because this is the physiological changes happening just normally in the process of developing hiatal hernia. And that kind of discussion need to be done before the surgery. It's very important. And again, a good number of patients, they do improve their gastric motility because you are correcting the anatomy, and patient's stomach is getting big space now, functional space to work on the food. But again, some patient, it may not work. So it's very important to talk to them. And there's a very interesting study which is done by our colleagues in Germany, where they look at the gastric emptying study, as well as they look at the esophageal motility over the time of one simple swallow. And these are the things they see when it comes to a study where there's a solid phase of the food is getting easily going to the stomach, but over the time, even in the phase of first, second, and third swallow, look how ineffectively it is getting cleared. And that is an area which we don't know very well, don't think very well. And the same way, in the stomach also, the same thing happened, we don't understand very well. There's many things, many pathophysiology in the hiatal hernia, functional and physiological changes in the esophagus, in the crura, in the diaphragm, and in all this membrane, and the functional perspective, what we are talking about, we don't know much. As Dr. Garagoslu was telling, we need more work on these areas. And the way we envision just doing a surgery to fix it, it might not be that simple. It might be more than that. It might be role of entirely different thing. It might be role of the dynamics of the circulation of the blood vessels during the change of this hiatal hernia happen. It might be completely different than what we are thinking about. It might be a leaky lining of the esophagus causing a lot of symptoms. A lot of patients who are sent to me by the surgeon because they develop this chronic cough. They also feel burning sensation of their pharynx. They don't have sinusitis. They don't have respiratory problems, but they do have these upper respiratory pharyngeal symptoms. The ENT doctor do their study, I do my study, and I don't find anything. So we talked about hyperalgesia. We talked about a totally different perception of the nerves of different areas. It might be something with that. We might think about the modulation of the nerve rather than something else. And a lot of work needs to be done for that, and we're looking forward for the challenge. I think that's about the diagnosis and the workup for the giant hiatal hernia. I can tell you, we don't know probably a lot. We just know the tip of the iceberg. We have more to work. And once again, I would like to thank Dr. Garagoslu to invite me to come here and talk a little bit about the diagnosis and the workup.
Thank you, Dr. Atiq. It's really a privilege to hear you, and it's so nice for a surgeon to have a gastroenterologist who keeps him out of trouble. So for my suggestion to the surgeons in the audience is get yourself an expert like Dr. Atiq, who is an esophagologist, who will keep you from hitting the mines in the minefield. So thank you, Dr. Atiq. It's a pleasure. Thank you. In my 29 years now, I feel like an old man, of doing medicine, I have met really two physicians that I would say humble me every time I see them, every time I speak to them, and really they would be people that I consider to be a physician's physician. And we have both of them here today, and they're going to speak to us. The first one is Dr. Fortune Alabi. It's really my good fortune to know Fortune. And he is the founding member of Florida Lung and the director of the critical care at Advent Health Celebration. Dr. Alabi is going to speak to us about the pulmonary and cardiovascular complications of hiatal hernias. Thank you very much.
Thank you very much. Thank you, Farid, for the very kind introduction. I know that Dr. G and Dr. Atik, they've talked at length with the anatomy. I have some slides which I'm going to skip them because obviously, the classification that we have there is from 1926, according to Dr. G, and it's not really applicable now. So, as a pulmonologist, we know a little bit about hiatal hernia or acid reflux as it, there's association with lung disease. We took lectures in medical school and we did some few lectures in internal medicine, and that's about it. So I don't remember having a lecture as a pulmonary fellow as to the importance of hiatal hernia. And then we look at tons of CT scan. Myself and my partner, Dr. Fred Ume, that is going to be talking to us about the postoperative management of this patient. What I would like to share with you today is my experience over the last 6 years or 7 years since Dr. G came to Celebration. When he first arrived, over this course of time, we've taken care of hundreds of patients with hiatal hernia. At first, we were seeing them just for postoperative evaluation, and then we also took care of these patients in the postoperative ICU and also on the floor. I've never looked at it as a pulmonary disease, but with time, patients will come into the office, apart from their GI symptoms, which majority of them have, they will also complain of palpitations. Some of them complains about weakness and tiredness. Some of them complains about shortness of breath. And then we see them in the postoperative care months down the road, and the patients will tell you, I feel much better. My shortness of breath is gone. Because we've always assumed that for those patients with giant hiatal hernia, the mechanism of their shortness of breath is related to the size. And so when you see an hiatal hernia that is not really affecting the lung volume, we've always felt this patient is unlikely to be having shortness of breath from it. But over the last few years, I think my view about this have changed, and I'm going to share some of this with you. So I'm not going to belabor you with all this because I've talked about this at length. So, the epidemiology, the sliding is the most common. The paraesophageal, less than 5%, and it's responsible for majority of the patient that we see, because of the size, the type 3, the type 4, that has the big chunk of the stomach and sometimes some of the intra-abdominal organs in the chest cavity. Obvious risk factor, obesity. Also, a big one is age. As we get older, at some point, we're all going to develop hiatal hernia. If you look at people older than 50 years old, almost 60% of them will develop it. The definition of giant hiatal hernia, differs depending on which paper you look at. Some people look at the size in terms of, if it's greater than 5 centimeter, whether the 5 centimeter is endoscopically or 5 centimeter is based on looking at the size on the CT scan or the chest X-ray, is not clearly defined. But I love the definition that is based on the percentage of the stomach that herniated into the chest cavity. So they say if at least 30% of your stomach is within the chest, the patient will qualify to have a giant hiatal hernia. I'm going to skip through all these since we've talked about it. But from a pulmonary standpoint, I think the type 3, the type 4 are the ones that, really we get excited about, because we can see it on the chest X-ray, we can see the size of it, we can see the lungs compress, we can see the movement of the heart being pushed to the other side. And in our mind, we've always felt if a patient comes in complaining of shortness of breath, and they have a big hiatal hernia that we could appreciate on the chest X-ray on a CT scan, then we feel like maybe this patient needs to go for some kind of surgical repair. But obviously, that is not the full story. So there are more to it than just looking at the size. But again, I think it suffices at this point to know that there are type 1, 2, 3, and 4. So I'm not going to waste much of your time. I'll just skip through it since Dr. G talked extensively about the types. And I'll just move into the complication. So this is what a typical chest X-ray looks like. When we see this, we get really excited. The patient comes to us, whether they have cough, or whether the patient have asthma that is uncontrolled, or whether the patient have some shortness of breath. We could see it, the airflow level, in the retrocardiac region. And then, the patient likes to see that too. Say, yes, you have part of your stomach in your chest. So part of the signs, gastric bleeding, Dr. Atik talked about it, obstructive symptoms. Sometimes they could develop gastric volvulus, strangulation, like a patient that I saw actually yesterday, coincidentally. They could have perforation, they could have ischemia, and then most commonly, majority of these patients will have some form of gastroesophageal reflux. So when you look at the complication that arises from the hiatal hernia as it relates to pulmonary disease, there are those that are related to the reflux itself, and there are those that are related to the presence of the hiatal hernia, independent of whether there's reflux or not. When you look at those associated with reflux, laryngopharyngeal reflux is very common. Patient comes in with chronic cough that you've treated them for asthma, post-nasal drip, and all they have is just some form of silent reflux. And that's the reason they have this globus feeling of something, a lump at the back of their throat, that they always feel like they have to cough all the time. Majority of the time, the cough could be dry or non-dry, but this is something that you have to think about sometimes. And surprisingly, majority of them would not have, they won't complain of any heartburn. They have no pain at all. So the absence of pain shouldn't dissuade you from entertaining this possibility. Hoarseness with laryngitis, patient with uncontrolled asthma, they're taking their rescue inhalers frequently despite being on adequate standard therapy for asthma control. It's always important to evaluate them for the possibility of silent acid reflux. There's also an association between obstructive sleep apnea and acid reflux, as well as patients with recurrent pneumonia. When you look at the pulmonary complication, shortness of breath is the big one there, and I will talk more at length about the mechanism of the shortness of breath. Atelectasis is common depending on the size of the hiatal hernia, if it's pushing on the lungs. Obviously, restrictive lung disease from pulmonary compression. And again, there is pulmonary fibrosis from those patients with recurrent aspiration. Whether the aspiration is responsible for it or whether it just contributes to the progression is still debatable in the literature. And then there's the history of the patient that presents with recurrent pneumonia. So when you look at the mechanism of shortness of breath, for years we've always thought it has to be the size of the hiatal hernia. If they come in with their stomach in their chest, some of the intra-abdominal organ like the type 3 and the type 4 hiatal hernia, I think we do a pulmonary function test, their lung volume is compromised, their FVC is reduced, then you make a case that part of the patient's shortness of breath is related to the intra-abdominal organs that are malpositioned into the chest cavity. Again, if they have atelectasis, you could make a case if half of their lung is compressed. And then there's a compression of the left atrium, which is entirely new. It's something that I did not know anything about until the last 6-7 years after I started working with Dr. G closely on some of these patients. And then the compression of the IVC, and patients just complaining of tiredness all the time. and then they tell you that, after I've eaten, I just feel tired. We've always felt, if you eat and you feel like you need to take a nap, it's fine. But I'm not talking about postprandial sleepiness, but postprandial tiredness. They just feel fatigue, And sometimes it's just reduced venous return, going back to their right side of their heart, just because of the distension of the stomach. And then when you look at the cardiac complication also, this is also new, to me, in particular in the last 6 to 7 years. This is nothing that I was taught as a resident or even when I was going through my fellowship. And then some of the patients that we've seen over the last 6 years that have palpitation, that have, recurrent atrial fibrillation, that they have to be cardioverted frequently. And then they go in for hiatal hernia surgery. And the patient comes back, and then you see that there is a strong correlation and says, since my repair, my palpitations just disappeared. And also, I've not been cardioverted, So I started looking into it. I said, is there a relationship between these? And surprisingly, I will share some of those with you. Then the issue of the left atrium compression, I have some slides to share with you also, and how that could account for some of their shortness of breath by the increasing pulmonary venous hypertension, because the pulmonary vein returns back to the left atrium. If there are compression of either the pulmonary vein or compression of the left atrium, it reduces the blood flow back to the left atrium, thereby could lead to some form of pulmonary edema, or just not frank pulmonary edema, but the physiology of pulmonary venous hypertension resulting in shortness of breath. Angina pectoris also. A most common cause of chest pain is actually, GI. It's not the heart. Obviously the GI one won't kill you majority of the time. So when somebody comes in with chest pain, we're always worried about the cardiac origin of their chest pain, because you could die if you have a CAD that is undiagnosed. But surprisingly, there's a mechanism from patients with reflux, whether it's the esophagitis, whether it's the irritation of the pericardium with the position and the compression of the hiatal hernia on the surface of the heart, resulting in some form of inflammation, vasospasm of the coronary blood flow, resulting in angina pectoris. I think there's a lot of hypotheses there, nothing definite at this time. And then there's issue of cardiac tamponade also, depending on the size of the hiatal hernia. So this is an example. The A is a normal coronal view of the CT chest, where you can see the heart very well, see the left atrium, the AV groove, you see the coronary sinus, you see the position of the esophagus there, and then behind it is the aorta, and in front of the esophagus also, you see the IVC. And then on the B, you could see a patient with a giant hiatal hernia, and the closeness of these to some of the cardiac structure. The position of the left atrium that is being compressed. You could see the effect on the coronary sinus. And also, depending on if it's a little bit more to the right side, might also compress the IVC also. And this is a nice picture of a patient. The A is a preoperative. The left atrium is squeezed. And then you look at the postoperative on the B side, where the hiatal hernia has been repaired, and now the left atrium, you could see that it's a little bit fuller in terms of the blood flow into it. The B side is an echo. You do an echo, you do a lung parasternal view, where now the left atrium is all the way down posteriorly. And postoperatively also, you could see that there's more filling into the left atrium compared to the echocardiogram with this in C, whereby the left atrium is compressed. And if you do a 4-chamber view, of an echo or so. The structure on the right side, on the left side are the right side of the heart, and the structure on my right are the left side of the heart. And you can also see that the left atrium appears to be compressed compared to the postoperative period, whereby the left atrium is fully expanded. This is a picture I saw online, so I decided to share it. A patient that presented with recurrent non-ST elevation, myocardial infarction, and had a left heart cath with normal coronary vessels, and EKG looks abnormal. Cardiac enzymes were slightly elevated, and this is just an example. The patient was actually in shock. This is a large, hiatal hernia that appears strangulated and obstructed with a cardiac tamponade physiology. So what about the mechanism of the atrial fibrillation? If you look at the prevalence of atrial fibrillation, it's about 1 to 2% in general population. The older we get, the higher the chances of developing this. If you look at patients with hiatal hernia, the prevalence is higher. The mechanism of it is related to both the reflux and also to the hiatal hernia. If you just take patients with reflux without hiatal hernia, the incidence, the prevalence of atrial fibrillation is increased. When you have both together, it's even higher. And there are tons of studies that have shown the resolution of atrial fibrillation, especially in young people with repair of the hiatal hernia. So this is just, a little bit cartoon that I pulled there to explain the mechanism. There is the autonomic activation because of the position of the left atrium, very close to the periesophagic blood flow as well as nerves. There could be an esophagic cardiac reflex. There's a closeness to the vagus nerve that can also cause arrhythmia. And then there is the direct irritation of just the hiatal hernia pressing on the heart itself. And then this is another study that I want to share with you, a paper that was published in 2016 by Bala that took patients with hiatal hernia, looking at patients with GORD and about 502 patients with gastroesophagic reflux, and divided them into those that has hiatal hernia compared to those without it. And you look at the prevalence of atrial fibrillation in them. The patient with hiatal hernia, the incidence of atrial fibrillation is higher compared to the patient without it. And also, when you look at it in terms of the size, the larger the size of the hiatal hernia, the higher your prevalence of atrial fibrillation. This is also another study from 2013 by Ragini, where over a 30-year period, they took over 100,000 patients diagnosed with hiatal hernia, and they look at the prevalence of atrial fibrillation. About 8,000 of them have atrial fibrillation, which is about 7% of that population. And you remember that I shared with you that the prevalence in general population is about just 1 to 2%. So when you look at patients with hiatal hernia, the prevalence of atrial fibrillation tends to be higher. This is another study that looks at the prevalence of atrial fibrillation with hiatal hernia compared to general population. The blue bar is the patient with hiatal hernia, and the red bar are the patient in the general population without it. When you look at it, irrespective of your age, the presence of hiatal hernia increases your probability of having atrial fibrillation. The A is the male, and the B is the female. And likewise, when the presence of hiatal hernia increases your probability of having atrial fibrillation irrespective of your age. But interestingly, I just want to share this. It has nothing to do with the slide, but I find it very interesting. that if you have atrial fibrillation, we know that most of those patients, they are survivor in terms of development of stroke, in terms of development of congestive heart failure, and in terms of overall survivor, tends to be a little bit worse than just, normal people without any atrial fibrillation. But if you have a hiatal hernia with atrial fibrillation, for some reason, it reduces your chances of having bad outcome. And I don't know why. And I look everywhere and I couldn't find out why. So I just, so it's one of those things that on one hand, if you have hiatal hernia, you have a higher chance of having atrial fibrillation. But if you're going to have atrial fibrillation, I think it's better to have it with hiatal hernia because it prevents you from dying from it. And then I'll finish up by showing some slides with idiopathic pulmonary fibrosis. When we look at the CT scan of patients with pulmonary fibrosis, majority of them will have hiatal hernia on the CT scan. And then we always question all our patients with pulmonary fibrosis for the presence of reflux, because we know that undiagnosed or treated reflux contribute to the progression of the idiopathic pulmonary fibrosis. Again, whether the presence of the silent reflux is responsible for the pulmonary fibrosis is still not well known, but we do know without a fact that if you have pulmonary fibrosis from any other cause or any reason, the presence of acid reflux going down into your lungs will make the disease to be worse. This is a nice study where they took patients with 3 common pulmonary diseases. They took patients with IPF, patients with COPD, and patients with asthma, and we look at, on a CT scan, the probability of finding hiatal hernia. In patients with IPF, about 39% of them, you could see, a well-defined hiatal hernia on their CT scan compared to patients with asthma or COPD. So again, this is just to buttress the fact that patients with pulmonary fibrosis tend to have hiatal hernia more than the other respiratory disorders, and we should look for it and we should treat it because it's possible that it's contributing to the etiology of the disease, but definitely it will contribute to the propagation or the progression of the disease. So it has to be treated. And then if you have it with IPF, your mortality is a little bit higher. So this is the study from that was published out of Emory, where they took patients with IPF without hiatal hernia compared to those with hiatal hernia, and the mortality is higher. So I finish up here. So I've been able to share with you that the size of the hiatal hernia, definitely the bigger it is, the higher your likelihood of having some form of pulmonary compression or cardiac compression. But the size does not explain all the symptoms. The compression, it might be a small hiatal hernia that is not giant, but depending on the location and what structure is being pushed or compressed, that might also explain some of the symptomatology of the patient. I will stop there. Thank you very much.
Thanks, Dr. Alabi. It's very interesting that you mentioned about the anti-reflux with idiopathic fibrosis, because everyone that has a lung transplant gets an anti-reflux operation, which obviously goes along with what you had to say. Thank you.
Thank you, Fortune. We are fortunate to have a lot of people watching this program. I think the last count is over 100, and so a number of questions will be transmitted, and we will have a panel discussion at the end. So thank you, Dr. Alabi. So Dr. Alabi made it very clear that we're talking about a cardiopulmonary disease, and really it just requires a re-understanding of what's going on. I'm going to get into the surgery world a little bit, because after all, this is a robotic surgery symposium. And we're going to talk about the surgery and show you a video of how this surgery is done. It is important, I think, from a surgeon's standpoint, to stop talking about archaic things like that you see on this slide. Pathophysiology hernias, large, giant, intrathoracic stomach. We need to understand that these are really relics of the past. And as my other colleagues have described, hiatal defects have major physiologic importance, and these terms really don't belong anymore, because these are the reasons we have operated, but now we're understanding that the indications for surgery are really physiologic rather than size and things that you see on an X-ray. Again, I spoke to you about the zebras and horses. I want to just point out that it's interesting. Theodore Woodward is a medical physician at the University of Maryland who in the 40s coined this term of hoofbeats being horses rather than zebras. But he did this for the medical interns. I think it's very important as we have become more sophisticated to understand that in making diagnosis of complex disease, you have to look for the zebras. And this situation really is a zebra. But many medical professionals seem to forget that zebras do exist. And so getting to diagnose and treat these things is very difficult if you're looking for horses. We went over this slide before. From a surgeon's standpoint, this is very important because, and I'll use an example. Back when I was a resident, we had a classification for aortic dissections, and it was the DeBakey classification. And to be honest with you, no matter how many times I looked at it, it made no sense at all because it was an anatomic classification of dissection of the aorta. Then there came the Stanford classification in the 1990s, which really typed aortic dissections into ones you should operate on and ones you shouldn't operate on. Surgeons are simple people. We need stuff like that. And this classification of hiatal defects is really important, that we're either dealing with the small type 1s and then the type 2s are the things that we have been discussing. Frankly, I believe that our data is going to show that the type 2s are a lot more common than we think, and the type 1s are actually probably less common, and they're a different animal. So we're going to talk about, these are our patients that we're going to talk about, the zebra. Dr. Lukatic, one of the giants in thoracic surgery, and his colleagues are pioneers in a minimally invasive approach to what they called paraesophageal, but really these are the hiatal hernias we're talking about. And this was 100 consecutive cases, which was reported about 20 years ago. And the main issue that, as you can see on this slide, is conventional open surgery has low death rates, but the complications are significant. And he felt that the paraesophageal hernias require conventional surgery in most places, and laparoscopic surgery should be for the smaller ones. This is a SAGES document, the Society of the American GI and Endoscopic Surgeons, and really this shows you the data up to about 10 years ago where really the larger hernias have all been done with open surgery. Everyone really understands that when you do the laparoscopic surgery, the technology is really not sophisticated enough to deal with this problem. And a lot of our problems comes from treating these things laparoscopically. So 97% open transthoracic, some done transabdominal, but mostly open. This is a paper from 2004. And the significant point is the conclusion that minimally invasive techniques have been applied to the repair of giant hiatal hernias, but have been associated with very, very high recurrence rates. Frankly, a 40% recurrence rate is as much like you didn't do surgery at all. This is a statistical situation. So really, the question is, what's wrong? And I think the surgeons have taken brunt of the problems because they think that the surgeons are not good enough to do this. And I can tell you, it is not the surgeons. It is the technology of laparoscopic surgery that has made it very difficult, and we do what we can with what we have. This is a paper from Mayo Clinic recently. There are a series of 118 patients in 10 years. Again, I want you to pay attention to these numbers because we'll be showing you some numbers later. Laparoscopic Nissen fundoplication for large paraesophageal hernias was associated with an increased incidence of leak and reoperation when compared to the Belzi fundoplication, which is done through open left chest approach. And that should be considered when deciding to operate on these patients. So this is their conclusion of really experienced surgeons. These are the people that I trained with, and basically they're saying that the only way to do this is open if you're going to get results, and that's true. And again, this is not new information. I think this slide is very telling. This is a review of all the published laparoscopic literature. They did a Markov Monte Carlo decision analytic model, which basically puts everything together and into this washing machine, and it comes out saying, what should you do? And the bottom line is the complications of laparoscopic surgery are so high that they recommended watchful waiting in 83% of the patients. This is the platform from which we're trying to jump. And this is what most of our colleagues think about. Now, again, this is from 2002. This is 20 years ago. And everybody's thinking like this. And frankly, things have changed a lot. And we want the audience to understand that this does not apply to what we're doing today because robotics has changed the world. And this is the truth. Talking about robotics, this looks like a very cheap plug for our textbook, but it is not. I'm going to make sense of this. This is the textbook of robotic surgery that just came out. We're very proud of it. I've had the privilege of working with all of the people who are speaking today and others like Vip Patel, Dr. Giolonotti, giants like Rob Poston, Dr. Grusner, Mark Meyer, and really the who's who of robotic surgery. It's a 1,500-page textbook of robotic surgery. The proceeds of this textbook are going to go to a fellowship in robotic surgery for the Society of Robotic Surgery and CRSA. So we mean well by this. But the point is that when this textbook came out last month and was reviewed, this is what the reviewer said. Robotic surgery aims to erase the artificial boundaries of specialization. I spoke about this earlier, based on regional anatomy. So actually, I stole everything I said in my first talk from the reviewer. This is how the world sees robotic surgery, and we're very proud of that. And we're showing you today that with this condition, we're talking about cardiovascular disease, thoracic disease, GI disease. We're erasing all kinds of boundaries. In treating this disease, the robot is used for transhiatal entry into the chest, wide anatomic dissection of the mediastinum, and it obviates the chest incision with all of the associated complications. This is the bottom line of this. We are not trying to do laparoscopic Nissen fundoplication, put the robot in just to do the suturing. This is not what we're talking about, and the audience needs to understand that. The reason you don't want to do a thoracotomy is seen in this slide. Everybody knows this. Thoracotomy is a disease just because of the physiology that changes as a result. It affects the immune system, the inflammatory response, decreases lung function, significant morbidity and pain, high mortality in the early patients who are going to have these conditions, very extensive procedure, and the idea is to obviate all these things with technology. And that's the point of the robot in Robot 2.0. We started to think about this about 10 years ago, and this is our first publication of robotic assistance in 2014. And again, this is a chest operation. So you need to do it like a chest operation, you need to take care of the patients like they had chest surgery, et cetera, et cetera. So the operation uses a double lumen endotracheal tube and single lung ventilation at different times of the surgery. The surgery will go through the hiatus, as I will show you, enter the chest, and do a pleurectomy, separate the lung from this, and so forth. This is not just pull the thing down and then put a couple stitches. And these are the phases. Double lumen intubation, single lung ventilation. So at the end of the operation, you need to make sure their lungs are expanded and so forth. So a lot of chest issues. 2 insufflators are used. When your CO2 is entering the chest, now all of a sudden the abdomen is no longer visible because the tent is coming down on you, so you need to stay up with it. But of course, when the CO2 goes into the chest, now you're getting tamponade, and you're getting basically a a patient who's getting tension pneumothorax. With 15 millimeters of mercury pressure, your IVC pressures of 10 or so forth are going to have trouble. So this is a very complex thing. I talk about it like twirling plates. You've seen the acts like that. This is what happens, and it requires a dance. Open the hiatus, gain access to the pleural space, mediastinum, and then you have, with the double lumen tube, you drop the lung, you have some time so that you can go put a chest tube in, go back to the robot, and continue with the surgery. And the chest tube can either go from the outside or from the inside of the abdomen, and depending on the situation. Pleurectomy is done. Separate the lower lobe of the lung from this, like Dr. Alabi showed you beautiful pictures where you got to dissect it off the heart and the lungs and so forth. And you have to dissect the esophagus. This is all about the esophagus. You have to get this esophagus dissected all the way up behind the heart to the level of the carina if you're going to get the appropriate reconstruction. And it is really important to understand that this is a surgery with no net under you. Getting into the back of the heart or some vessel up into the mediastinum through the hiatus requires significant sophistication in the operating room. We have used the collis esophageal lengthening as a kind of a Band-Aid to get the longer esophagus. We don't need that with the esophageal dissection. We remove there is always fatty tissue. We have always talked about how much stomach goes up, but what people who are not surgeons don't know is the whole retroperitoneum slides up into the chest. And that lump of fat is actually what's compressing the vena cava and causing lots of trouble. And so you have to free that up, bring it down. You have to make sure that everything goes where it's supposed to be. It is a reconstruction. Sometimes you have to open the diaphragm actually to enter the chest to do this because you can't go around the corner of the hiatus. At the end of the operation, again, the patient has to be scoped and the lung has to expand. The other thing is endoscopy is used in this surgery as a way of looking at things from the inside as you're planning this. I tell people this surgery is like taking a Gordian knot and undoing this knot. And it's very complicated. It is not what we imagine it and what we were taught. And then the patient has to be extubated on a delayed fashion. My colleague, Dr. Ume, will be talking about that. So let's show you a video of this surgery. Let's see if our video will work. Oops. There we go. So we're looking here at the hiatus. There's a vessel that always crosses over the caudate lobe, and we have to take that to gain access. This is the right limb of the crus on the right side of the picture and the left limb of the crus. This surgery has to be done bloodless. The old ways of using harmonic scalpels and things like that are useless because they destroy the anatomy. You have to get into the correct anatomic position. We are now entering the chest. We use a hook cautery, and the blood will stain the tissues, and you can't recognize the anatomy. So we are now, again, the right limb is seen. That's the stomach, which is a minor issue. The rest of the stuff is up in the chest. So even when you bring the stomach, which is what we've done over the past, that's irrelevant. It's the other stuff that has slid up that needs to come down. We're opening the tissues. There is a certain anatomic layer that you have to get into that is avascular. If you're getting bleeding, you're in the wrong place. And it's like basically, and then now you're going into really a rabbit hole, and you're not going to get out of it. You're going to get bleeding, you're going to have problems. So you have to stay in the right plane. My colleagues from the operating room, my colleague, Mr. Amin Burri, will talk to you more about what the table side assistants do. They are two of them. And that way, the surgeon is actually operating with 6 hands. And you see, we're entering the left pleura. The pleura is stuck to this sac, as it's called. This is not like pull the sac down. The lung is not going to let it come down. The lung is on the right side of the picture. We are separating it, and we've already entered the pleura. So now the anesthesiologist has to drop the lung because now we're going to get tension pneumo. Now we will push the stomach over to close that hole so the CO2 doesn't keep going in the chest. And now we're going to get underneath the esophagus. The esophagus is being held up by the grasper. And everything here is in the chest. This is not in the abdomen. So if you stop at the hiatus, you're not going to do this. Now, unfortunately, people use these euphemisms of robotic, this and that, just because they kind of use the robot. But this is what the robot is good for. Dissection in spaces that are small, that you can go basically use the hiatus as a door into the chest. The atrium is in the top of the picture. You can see the aorta at the bottom of the picture. We're taking all the branches. But again, this is bloodless surgery. You cannot have bleeding. You get bleeding, how are you going to fix this? And so this is all about prevention rather than fixing. So we are going up. You can see the vagus nerve right where the hook is. That's the right vagus. And we're going to now get underneath the esophagus. But with all of that, you see the stuff isn't coming down. So if you think that you can just pull it down and do a little wrap and you're set, you are truly mistaken. The tough dissection is always on the left side because it seems to go into the chest. Now you're going to see the aorta is at the bottom of the picture, being separated from the esophagus, and we are now getting the inferior pulmonary ligament away from this stuff so that the esophagus is never short. The esophagus is all twisted around, so you just need to straighten it out. That loop is put around and slowly we start to kind of creep up on the esophagus and bring everything down. The retractor is put in by the second assistant, and again, it's not good enough. You have to keep going. Now at the top of the picture is the superior pulmonary vein on the left side. And if you were to think of this on top of the patient's body, we're getting all the way to the carina here, so to the sternal notch. This is not simple surgery. Now you see, I'm lifting the left lower lobe. You see, we're inside the chest. Now we could do a lobectomy. This is the whole idea. Someday we're going to do a lobectomy this way, but this is really our way of learning. This is as I said earlier, this is my Gemini, and we'll get to the Apollo soon and land on the moon very soon too. So, but the fun thing is that in this situation, we have understood a disease that I never thought I would be interested in. I never started this journey being interested in hiatal hernias, but it's a fantastic journey. Now we will switch to laparoscopy. And the reason for that, this is the reconstruction now. This is not about fundoplications again. So this is sutures that are put in. Those are made out of vicryl mesh. They are absorbable, so they cause a lot of reaction, and it allows for the muscle to heal better. The reason we use laparoscopy is that instrument on my right hand is an instrument that's like 2 hands. It passes the needle back and forth. So now I have 3 hands, and we're much faster. This operation has to be done very quickly because we have tension, pneumo, we have lots of stuff going on. So physiologically, the patient will not tolerate this for too long. So I like the reconstruction to be done by laparoscopic technique and not robotic. The robotic reconstruction, the robot is not designed for this kind of thing. It's designed for dissection and working in a small space. Sewing with the robot, because of the haptic issues, etc., are not very good. The esophagus is suspended onto the crus. You see the stitch from the esophagus. So that esophagus is now going to sit where it was living before all this happened, right at the level of the hiatus. We didn't do anything. The G junction obviously is below the the hiatus. Now the esophagus is sitting normal. And then people are like, do you fix this primarily? Of course. There's no need for mesh. If you do the dissection, you don't need to put a plug into something. The tissues will come together very nicely. So this is an anatomic reconstruction rather than just putting a plug of something in there thinking you did something that you did nothing on. The next is to make the valve. This is a suture from the lesser curve of the stomach, it's going to go to the right limb of the crus, and when it's tied, you will see the esophagus is going to intussuscept into the stomach by 2 centimeters, making the gastroesophageal valve. So the whole concept is this valvular structure, just like the door analogy I used, is suspended onto the hiatus. It's not going anywhere. It's going to basically be a functioning situation. So 3 such sutures are used to make the valve, so that from the lesser curve all the way to the greater curve, you can see that. And basically, this reconstructs the hiatus, granted in a human hand as opposed to nature's hand, but it is a reapproximation of the normal relationship of the structures. And once this is done, everything is where it should be, and everything works. The atrium, the pressure is gone, the esophagus is straight, the obstruction is gone, and then the last thing we do is, this is a patented material. This is a healing accelerant made out of fibrinogen and thrombin. That's actually, we have the patent on this. And this makes that area heal so that much faster and so forth. So now, as I mentioned, this is doing an endoscopy preoperatively and then postoperatively, depending on your system, is very, very important, because it's using, again, the analogy of the mitral valve. I want everyone, when they're talking about the GE junction, to think about the mitral valve. We learned that when you're fixing the mitral valve, if you do a TEE before the fix and then after the fix, now you know what you did. And so if there is a question, I will use endoscopy to tell me if the valve has to be tweaked and so forth, so you don't leave the operating room with problems. And this is a paper from recent literature that shows that endoscopy is a significant adjunct to this type of surgery. For planning of the surgery, for repair, understanding the repair, it's really the TEE to the heart valve surgeon. The other one is bronchoscopy. Now, people don't understand that the importance of bronchoscopy, and really, this is chest surgery. In chest surgery, we have found bronchoscopy to be one of the most significant factors of fast-tracking these patients in their clinical pathways and post-op. Here's a paper that shows, I mean, this is almost 12 years old, but basically this should not be news to people, that anyone who gets a double lumen tube gets bronchoscopy afterwards to expand the lung, to be sure the secretions are removed. And then the next thing is the patient has to be scoped a few more times after surgery to make sure, because once their lung collapses and you get infections, then you got problems. So, anyone who's interested, there's a chapter in the textbook about all of these things, and I think that it is really important to have that as a reference. I have the privilege of showing you some data that is going to be published very soon. This is an 809 consecutively operated large hiatal hernias from our experience. And this is really the take-home message. 70% of the stomach was the median percentage of herniated stomach. As Dr. Alabi said, 30% defines the hiatal hernia, so that's the low level. But we've had it so some stomach is all up there. But it's really not so much about how much stomach is up there. It's about the fact that this helps us kind of get people to understand what we're talking about. Mean hospitalization is around 4 days. This is not an in and out surgery. This is chest surgery through the abdomen. The hiatal hernia recurred in only 0.4% of the patients. This is unbelievable, because we are dealing with, as we'll hear later on, with percentages that are much, much higher, 40, 50%. We had 1 leak, so for a 0.1%, and there was no mortality. This is the future of dealing with this disease, in my view, and as we understand the indications for the surgery, the complexities, I think we can really change the story of this disease. Thank you very much.
in the audience, just so you know, that was in real time. That video was not sped up. That's actually how fast Dr. G operates. It's thank you again, Dr. Ume. As Dr. G had mentioned, it's of ultimate critical importance to work with an excellent team. Dr. Alabi, Dr. Ume do a fantastic job and take care of all of our perioperative care, as well as Dr. Dole is here with us today. But next, Dr. Ume, please talk to us about how important it is for post-op bronchoscopy and re-expansion of the lung after surgery.
All right. Good morning or good afternoon from, I think it's still good morning, right, from Orlando. Thank you, Dr. G, for having me here. And actually, it's been an education working with you over the years, and I've had to obviously read a lot and try to understand the physiology, the pathophysiology, and the surgical skills and the surgical techniques involved. Because I've always believed, as an intensivist or as a physician involved in post-operative care, it makes a whole lot of difference if you make an effort to understand a little bit, not quite as much as the surgeons, but at least to have an idea what really goes on during the surgical procedure. I'll try to avoid getting into the definitions because obviously my data in terms of what is referred to as a large hernia is approximately 70 years old. So I'll defer that definition and the controversy surrounding it to the surgeons. You know, from our perspective, most large hiatal hernias, using the traditional definition, are mainly paraesophageal hernias. And they're either, you know, the type 1 or the mixed type. And a lot of them actually come in with a little bit more than just the stomach in the intrathoracically. And unfortunately, too, a lot of those patients come in, you know, in their later years of life for surgery, either because it wasn't done much earlier or they start having more symptoms as they get older. As one of my colleagues mentioned earlier, things like atrial fibrillation obviously will happen a whole lot more, and maybe the final push to get them to agree or to seek for surgical intervention. The interesting thing, though, is that older patients, yes, may have a higher morbidity and spend a little bit more time, you know, in a hospital following surgery, but they actually do pretty well in terms of quality of life following surgical intervention. And also, they do not have a high mortality from the surgery. So in essence, yes, they may look old. Yes, they may stay longer in the hospital, but it's definitely very beneficial to offer them surgery because it's safe and clearly improves the quality of life and avoids the other complications. So how do you move to the next slide? I've seen it here. So again, I will try to avoid getting into the controversies regarding the size and definitions of hiatal hernias. Most hiatal hernia surgeries are done electively when the patient becomes very refractory to medical therapy and have major symptoms, which include dysphagia, early satiety, postprandial pain that could either be abdominal or chest, and actually mimic angina pains, persistent vomiting postprandial, anemia from bleeding, and of course, severe dyspepsia, which some of them describe in very graphic terms in terms of what it makes them feel or how they wake up at night, gasping, can't breathe, and with very severe chest pain. It can also be done rarely emergently for acute volvulus obstructions, strangulation, perforations, or respiratory compromise. Prophylactic surgery at this point still remains controversial, but if you think about it, I'd rather have a surgery when I'm 40 than wait till I'm 80, because obviously my mobility and my length, being able to, at that point, you're more likely to have more comorbidities than when you are younger. So in essence, it may make more sense actually to have them done at an earlier age. Preoperative evaluation, it makes a whole lot of sense for the post-op physician to somehow acquaint himself with the patient. It's very reassuring for me as a physician to be able to have seen the patient preoperatively, to have an idea, how things looked before surgery. And also, the patient feel very comfortable meeting you and knowing that, yes, you'll be involved in my care following my surgery. There are some very salient things I always try to define. One is to very clearly define what their current symptoms are. Is it dysphagia? Is it chest pain? Is it postprandial vomiting, nausea, atrial fibrillation? And also try to have an idea what the previously attempted therapy was in terms of any prior surgeries, or was it just medical therapy? And then dig as much as possible to elicit all comorbid issues like cardiac or pulmonary diseases. This may involve seeing a cardiologist to have a detailed stress test, echocardiogram, and from the pulmonary perspective, we try to do a pulmonary function test. And of course, they would have done a detailed GI evaluation prior to being scheduled for surgery. Very important. I really can't stress this enough. I just call it a very robust personal review of the X-ray imaging. Not just the report. You've got to take a look at the images yourself and have an idea, what the size of the hernia is, what the other contents beyond the stomach are, and have an idea, the extent of any pulmonary atelectasis, which obviously will factor in your post-operative care. And also, use of chronic pain medications may look like it's not such a big deal, but you have to remember that for the first day or more, the patient will be unable to take anything by mouth. So in essence, you have to have a very clear plan what to do. Because if you already have a chronic pain issue, then you may run into problems with withdrawal and being able to control their pain following surgery. Also, other substance abuse like alcohol, smoking may also factor in as well post-operatively. So it helps to be very clear whether these are present before the surgery. Ongoing tobacco use, we all know, affects the rate of atelectasis in the post-surgery, and it helps to have an idea whether this is present as well. Some patients, if they have the right risk factors, you have to worry about OSA and trying to evaluate them if you have enough time. The surgical approach, obviously, I'm not going to kind of delve into it as much because obviously I have more people who are more knowledgeable than me. But the fact of the matter is, yes, it's robotic. Yes, it's minimally invasive. But if you kind of look at the video that we watched a few minutes earlier, that tells you how deep they dig into the thoracic. It's almost like having, like a thoracic surgery trans-abdominal. And unfortunately, too, we don't seem to quite often appreciate the amount of dissection involved, the amount of scar tissue involved, and the amount of disruption that you have to think about that will determine and direct what you do post-operatively. Very rarely they end up as open, but mostly it's all done laparoscopically with robotic assistance. The transthoracic one obviously will have a much longer stay with frequent need for chest tubes and mechanical ventilation. And definitely the pain management becomes very crucial. Then the reduced surgeries or past history of any kind of upper abdominal or thoracic surgery will suggest presence of very extensive adhesions, which would kind of affect the length of the surgery and may end up pushing to an open approach. And this also will affect what you do post-operatively. So the immediate post-op considerations is always going to be, where do I put the patient after surgery? Are they simple enough, well enough to go straight to a medical floor, or to go straight to like a regular post-surgical floor, or would they need ICU monitoring? Well, first, it depends on obviously your local availability of ICU beds and the experience of both the ICU team and the non-ICU crew. And more importantly, really, is to have a very close relationship with your surgeon, because each case, you may plan initially the patient may go to the floor, but then he goes in there, finds is a little bit more complicated than he thought it was going to be. So you've got to listen to your surgeon. You've got to work very closely with him and respect the fact that, only he knows how complex it was during the surgery. And that would help direct where the patient ends up being placed post-operatively. Clearly, presence of very severe comorbidities and extreme age also will factor into your placement. The length of the surgery, amount of dissection needed with significant bleeding or not would also affect what you do afterwards. And any intraoperative incidents which you'll be made aware of by the surgeon and by the anesthesiologist in terms of airway management, ease of placement of endotracheal tubes, and any other cardiovascular incidences that may affect what you do afterwards. And of course, if you need to be on a mechanical ventilation, which become very important with real large, with presence of intrathoracic, stomach, spleen, and other abdominal organs with very significant atelectasis, because if you do not do that, you very likely will end up with the lung staying collapsed and with more obvious chance of more complications. Also, patients that require very excessive opiate needs preoperatively, you have to remember that post-op, to give that much, they can't take PO, to give that much IV will clearly affect your patient ventilation. So you have to have other plans in place preoperatively to help you with taking care of that. So what do we really do when they come back from surgery? Very important to minimize your fluid administration. Because yes, you may just give fluids liberally just to maintain blood pressure or whatever numbers you want to keep, but other fluids would affect patients' ventilatory capacity. And you've got, we found a very judicious use of diuretics when appropriate has been very helpful too. Most importantly is to minimize your opiate administration. Because if you think about it, as some of my GI colleagues mentioned earlier on, they have esophageal dysmotility, delayed gastric emptying, which all gets worsened by use of opiates. So we tend to try to optimize pain control with a mixture of local anesthesia. We use Presidex, which clearly has a lot of advantages in terms of pain control, anxiety control, without really affecting the GI function or affecting your respiratory status. Some patients actually do well with ketamine as well. For the same reasons, it will give you fairly good pain control without depressing your respiratory function as well as having any GI side effects. Toradol may come in helpful, but unfortunately, due to its GI side effects, effect on the post-op bleeding and kidney function, you have to be a little bit more careful with Toradol use. And then using IV Ofemev, that's IV acetaminophen or Tylenol, has been very helpful as well. And Robaxin, and whatever you may have locally. So the key point really is to try to avoid opiates as much as possible. Presidex has an extra advantage that for most patients who have a very chronic opiate use, it tends to lower the amount of opiates they need for that first few immediate post-op period. So it comes in very handy. Yes, it may look expensive, but by minimizing your GI side effects, specifically gastric emptying and GI dysmotility, it may actually save you a lot of time and money in the long run. So again, as my surgeon, Dr. G kind of clearly pointed out, intraoperatively by using a double lumen endotracheal tubes with selective lung ventilation leads to a lot of atelectasis. So yes, they do some bronchoscopy before they leave the surgery, but we always try to set them up for bronchoscopy before they are extubated. So that way you do a fairly good pulmonary toilet and clean the lungs out, particularly for those patients with long-standing hernias with chronic atelectasis. Because yes, the bronch may look invasive. In the long run, it's much easier way to re-expand the lung and avoid any pneumonias. And of course, you try to enforce your strict early ambulation and encourage incentive spirometry as well. The DVD prophylaxis is always standard unless there's some major bleeding. Again, we try to kind of, while they're still in the ICU, you get daily chest images, which helps you to evaluate for need for extra bronchoscopies, and at some point, some patients may actually need some other interventions, either to relieve some pneumothorax or to get some pleural fluid off. The earlier you do it too, the better things will be in the long run by avoiding pneumonias. Once they leave the ICU, the next day post-extubation, they get a barium swallow to assess the GI, the gastroesophageal junction, and then it will help you determine when to start your PO feeding. Then as I said again, the long-standing hernias that have a delayed gastric emptying and motility issues may actually benefit from use of motility drugs. And then you have to have an experienced dietitian as part of your team to help you with dietary instructions. And we try to gradually get them to start oral liquids and slowly progress as tolerated. Then the chest tube monitoring and daily assessment for prompt removal as soon as feasible. Before they go home, we kind of work on their home health care needs. Some may require oxygen if they have other comorbidities, and they have very clear follow-up plans with X-rays if needed, and re-emphasize the limit on how much weight they're allowed to carry, and then set realistic expectations clearly in terms of expected slow resolution of their symptoms. And yes, it's very infrequent, but slight chance of recurrence down the road. And then dietary instruction with very low residue diet for a few weeks post-discharge also is very helpful. And try to get them some adequate pain medications to go home on discharge, and plans to remove any tubes that may have been left for various reasons. All right. Thank you, guys.
Thank you, Dr. Umay. Fantastic presentation. I think that one of the things I have learned about robotic surgery in the last 20 years is that it really does take a village to do this. Surgeons who think that they're just doing it on their own are mistaken. There is actually a chapter in our book that talks about an analysis of robotics in terms of the way the nuclear navy changed from conventional Navy to the nuclear Navy without accidents. And really, robotics is like that. So thank you very much. We need all the members to make sure that the end result is good quality surgery and results for our patients. Our next speaker is Mr. Amin Bouri. I have the privilege of working with Amin. He is the director intraoperatively of the thoracic and esophageal program and at Advent Health Celebration. I use the concept of a trapeze artist for robotic surgery. We try to find analogies, and I think trapeze is a very good analogy because the timing has to be right, or the person you're throwing up in the air is going to end up on the floor. And there's no net with what we do. So I'm on one end of the trapeze, Amin is on the other end of the trapeze, and our second assistant is the one jumping around in between. And our patient, of course, is the most important one, not to end up on the floor. So Amin is going to tell you about how we try to make this ballet work. Amin?
Thank you, Dr. Gargarzulu. Thank you for the kind words. In this presentation, we will emphasize the key elements that are important in establishing the intraoperative program for patients undergoing repair of giant hiatal hernia. This includes room setup, robot positioning, patient positioning, and anesthesia management. We'll also talk about specialty instruments that we use. First, we're going to talk about the surgical team. The robotic approach to repairing giant hiatal defects requires extensive coordination and collaboration at many levels. The nature of the procedure is complex and doesn't allow much for regrouping or reorganizing. That is why preventing issues from arising through accurate preparation is the key for successful outcome. And that is why having a dedicated team for this type of procedure is paramount. A specialized team that knows all the aspects and dynamics of this procedure is crucial. At the table, 3 individuals must work in a very small space and around very complex anatomy. The most important rule is to provide exposure for the consult surgeon. Knowing how and when to intervene will help with the flow of the surgery and decrease the operative time. This procedure requires working high in mediastinum using a laparoscopic approach. That is why there is no room for error. Anesthesia management. The anesthesia provider is a very important member of the surgical team. Every patient undergoing this procedure should have a double lumen endotracheal tube with a single lung ventilation. Knowledge and skills about placement and manipulation of the tube, of the double lumen tube, is crucial. Entry into the pleural space is part of the procedure. With the entry of CO2 into the pleural cavity, the tension pneumothorax needs to be addressed in order to maintain hemodynamics and preventing loss of exposure. A skilled anesthesia provider will have to place correctly so that in the event of pneumothorax, the ipsilateral lung can be deflated, thereby giving the surgical team time to place the chest tube and continue with the procedure. Now, how would we manage the pneumothorax? With the pleural entry, the ipsilateral lung is isolated. This allows greater space for CO2 accumulation and delay tension physiology until the chest tube is placed. A chest tube must be placed intraoperatively before proceeding. It is not necessary to undock the robot totally for placement of the chest tube. It is sufficient to only take one of the robot arms at the side of the affected side. The surgical team work effectively to assist the surgeon in the placement of the chest tube. 2 insufflators allow the maintenance of a normal peritoneum, as some of the CO2 is removed by the chest tube. Now we'll talk about the room setup and how we place and position the robot. The vision cart is at the right side of the patient along with the other devices, and the patient cart is positioned at the left side of the patient. The vision monitors are positioned so that the whole surgical team can see what is happening during the procedure. For the anesthesia provider to verify the placement of the NG tube, also to intervene when seeing movement of the diaphragm when further paralysis is required. And for the circulator, monitoring the procedure allows a quick reaction in terms of opening extra supplies, such as in the case of pneumothorax. It is especially important for the scrub nurse and the circulator to have continuous visual surveillance of the procedure. This allows accurate and timely reaction to the needs of the surgeon and the table assistant. The patient is placed in the supine French position. Arms are tucked, and the surgeon and table assistant stands between the legs during the different phases of the procedure. Rolls are placed under the patient knees, then the legs are secured with tape. The patient will be on steep Trendelenburg position, requiring a beam bag under the buttocks to avoid sliding. This procedure happens in 3 phases. The first phase is laparoscopic and gaining access. The dissection part is done robotically, and that's the second phase. And the third phase is also laparoscopic, which is the repair of the hiatus. The trocar placement is very important too. So 7 trocars are placed to effectively control the surgical field. The first trocar is used for the camera. Second is used for the liver retractor. The third is used for the second assistant for retraction needed by the surgeon using the second endopaddle. The fourth and fifth are for the robot arms, and the sixth and seventh are used by the first assistant to place contraction on the crural arc and create space for the surgeon. And this picture shows how the trocars are placed. For the robotic part, trocar number 1 is used for the robot camera. The trocar 4 and 5 are for the robot arms. And you see here that's the endopaddle, which is retracting the liver. Trocar 6 and 7 are used by the first assistant. During the third phase, which is the repair, the trocar 6 and 7 are used by the surgeon for the repair. And the scope can be used in either trocar 1, 3, or 5. All the fine work and dissection is done robotically, and the repair of the hiatus is done laparoscopically. This is superior to performing the entire procedure with the robot. For the laparoscopic part, we use a 10 millimeter 30-degree scope, and the scope is moved between trocar 1 and 5 depending on the best angle view. Now, docking the robot. When docking the robot, the trocars are introduced into the laparoscopic trocars. The patient cart is positioned to the left side of the patient. Access is obtained by placing the laparoscopic trocars first. Then robotic trocars are inserted through the laparoscopic trocars, as it shows in this picture over here. We have three main specialty instruments that we use: the endopaddle retractor, the endostitch, and the endokitner. And we'll talk about them in the next slides. The endopaddle retracts the liver, but more importantly, it elevates the diaphragm and opens the hiatus. And this video will show how the endopaddle is placed. The surgeon will place the endopaddle, lifting the liver, and you see how it's beautifully opening the hiatus. Now, once he's had it perfectly positioned, the assistant will hold the endopaddle, hold it in position for the surgeon while he uses a clamp to secure it to the table with the help of the circulator. And as you see here, it's holding it perfectly over there. In order to provide constant and controlled traction, the endopaddle is secured to the right side of the bed of the operating table using the multi-joint clamp shown in this picture over here. And that's how it's all placed and secured to the bed. That's the joint we talked about. The endostitch. This is the endostitch. The final step of the procedure is reconstruction of the hiatus and gastroesophageal valve. This is done laparoscopically using an endostitch device. It is a one-hand auto-suturing device that helps enhance the advanced laparoscopic procedure requiring endoscopic suturing. Its large jaws help accommodate a variety of tissue thicknesses. The endostitch allows the surgeon to accurately grasp the tissues with total control. It allows the surgeon to do with one hand what normally requires needle driver and a grasper, or two hands. And the endokitners are used by the assistant to provide counter traction on the hiatal opening. They can be used with the precision. The tip of the endokitner is padded, which add another protective layer by preventing accidental punctures and being gentle on the handling tissues. The assistant can work around the surgeon robotic arms using these endokitners. In conclusion, robotic anatomic and functional repair of the giant hiatal hernia requires a highly functioning team. This effort is a battle that calls for perfection every day. Every single member is unique and important to the team. And this effort is not achieved easily and requires tremendous hard work to maintain. The ultimate achievement is harmonious interaction of the team members whose expertise ensure excellent result for patients who otherwise would have undergone a thoracotomy. Thank you. Thank you.
Well, excellent presentation. Thank you, Amin. Very, very nice, and thank you for everything you do.
Thank you.
as I mentioned earlier, one of the issues is we think of robotics as just a tool that we're introducing rather than a whole change, a quantum leap forward in all of surgery. If you look at it that way, you understand that what happens in the operating room is only a piece of the puzzle. Once the surgery is done, the patient goes into the hospital program, and that piece has to work beautifully. Otherwise, all of the hard work really will not have its effect. This part is managed in our program by just a consummate professional and owner of this program, who is the clinical director of our thoracic and esophageal surgery at Advent Health Celebration. Ms. Hannah Holman-Quirk is going to talk to us about the design of such a program and all of the complexities. Thank you. Hannah?
Hi, thank you so much for having me here today. It's quite an honor to be speaking in the same session as everyone that went before me. I'm going to actually take us in a very different direction. Everyone before me spoke about the technical aspects of the surgery, the medical care after the surgery, even medications after surgery, but I'm going to take us in the direction of program growth, program development, program maintenance. So I have a position called patient care coordinator. I am a nurse at the hospital. I am not technically administration in the standard administration point of view. It's a position that was actually created by our chief nursing officer, and it was one of the initiatives that helped our whole hospital gain magnet status, which is a really big honor. There are only 300 hospitals in the whole country that have, approximately, that have this status. So as the patient care coordinator, I lead the program with collecting data on clinical practice. I've created the education for the program. I work in an administrative and research perspective as well. So creating a new program or initiative is quite challenging. It is well documented and known that 70% of change initiatives actually fail nationwide, whether in healthcare or just in business. And multiple studies have been conducted, surveys have been conducted, and there are three main reasons why initiatives tend to fail. And the first is poor communication. This is communication of the vision of the program or the change initiative, and a failure to communicate progress as it goes on during the change initiative. The other is a lack of leadership investment and also stakeholder buy-in. Those are the three most common reasons why programs fail. So we could have the most amazing surgeon in the world, which we do, and the most amazing post-operative doctors in the world, which we do, and the program can still fail. That's because the patient spends the majority of time not with the surgeon, not with the physicians, but everyone else in the hospital, and they need to understand the vision and the progress of the initiative. Now, our leadership luckily has shown investment in the program by just creating my position. So I'm going to focus on communication and stakeholder buy-in. Our vision is simple. We want to create a successful program for this specific surgery, which is a very unique surgery that isn't offered many other places. Now, for me, the most important strategy is making a multidisciplinary program. This is a team effort. There is no department that lacks value. Every single department on here touches the patient. They are a stakeholder. If one department isn't happy with the program or the surgeon, the patient will feel it. We want every single person that meets the patient to feel the culture of trust for the surgeon, to feel the culture of trust with the physicians taking care of them. And I see it every day. Every day I go into a patient's room and they tell me, oh, every staff member I run into, whether it's someone drawing their blood just to get morning labs, or the x-ray technician, they tell me how wonderful all our physicians are and how wonderful our hospital are. Every single one of these departments needs to feel like a stakeholder, and I probably didn't even include all of the departments. There's just so many to think of. So everybody that was just on that previous list should be included in multidisciplinary meetings. If you're starting a program from scratch, you want to have these people at the table before the program even starts. We want to know what challenges we might be facing before the program starts because we want to identify the barriers and obstacles and overcome them. Please always have the frontline staff review this as well. As wonderful as our directors and managers are, they don't always have a pulse on what the frontline staff is going through or experiencing, and the frontline staff is who has the best pulse or read of what the actual patients go through. So I don't think we can ever value their input enough. Now, if you are also starting a program from scratch, having someone like my position basically just stay with the surgeon, the nurse practitioners, and the patients for the first week or two of the program is invaluable. This would be someone who is more frontline, not someone who's a director, not someone who's a manager, but someone who understands the little nitty-gritty things about where things are located in a room. Who do I need to talk to in central supply to really get what I need? Who do I need to call in pharmacy to have a medication that we need immediately? And how do I navigate the software? So why have a multidisciplinary program? Well, the more opinions you get from the more perspectives you have, create expert opinions. It's not just one person's perspective, it's everybody's perspective, and you're finding the actual content area experts in that field. This is what creates stakeholder investment, excitement, and involvement. They are true partners in the program. Every department should be invited. Every department should have a chance to communicate, and this builds trust within the departments, but it builds trust that the patients feel. And it's also a very good form of word-of-mouth advertising, not just word-of-mouth advertising from one patient telling another patient that their family member, friend, whomever did well, but word-of-mouth advertising from department to department. When our occupational therapists talk to someone at system-level occupational therapy, that builds excitement and more knowledge and growth of the program. So in general, how to make it multidisciplinary? Well, have the multidisciplinary meetings. Invite everyone to the table. Everyone is invited to the table. Everyone has a chance to share their opinion. There needs to be open dialogue with data sharing. The data is the data. We need to review it. We need to look for problems. We need to see how we can improve and make things better. Even if our complication rates are 10% lower than the national average, one is too many. What can we learn from it? What can we prevent next time? Education sharing. Sometimes to this day, it still surprises me that when I make a new piece of education, every department wants it because they want to understand. Most people are hungry to understand and have an idea of what the surgery is and what to expect afterwards so they can better their part in the patient's care. This also gives other departments a chance to tell us the barriers they're encountering because it might not be something we think of. Ask them for their suggestions and partner with other departments. Examples of this include pages from the patient education book that I have written. Now, it would be much quicker for me to just write this myself. However, it took twice as long to have co-authors on it. But having co-authors on it doesn't just make it the surgeon's program, doesn't just make it the physician's program, doesn't just make it my program. It's not just my baby, it's now pharmacy's baby, nutrition's baby, occupational therapist's baby, because they were part of writing the book. They are the experts in that area, so now I know that I have their opinion. And they're also authors on this book, so they're invested in how the patients perceive it and whether or not their time resulted in improved patients' perceptions and outcomes. So when I have my page on medications that they're expected to have in the hospital, I wrote that with a pharmacist. The 6 pages I have on nutrition after surgery was written with nutritionists and the 4 pages we have on post-surgical exercises was written with occupational therapists. This is how you create buy-in. This is how you create partners in the program, and it has to continue because we always have to try and strive to do better. The administrative part of my job is basically I'm a liaison between everyone, the office, the patients, the OR team, and the physicians. The research part of my job is I collect data on all the surgeries. I look at outcomes, readmissions. I give that information to the surgeon. I give it to even the nurses and administration, of course. This helps ensure data dissemination. The way that we do that is through these multidisciplinary meetings. This helps us with quality control and quality improvement and identify any best practice models that maybe we don't know about. As far as the clinical practice goes, I round on the patients separately from the surgeon and the nurse practitioners. I will round on them with them, but I see them separately. And that's just to check everything in the room, check the tubes and drains, make sure that it's set up correctly. I also work with the different departments like central supply, pharmacy, making sure we have everything we need. One of the first things I did, believe it or not, was just make a list of supplies. Making sure that we have all the supplies we need, making sure we have all the medications we need, and provide the clinical expertise that I've gained throughout the years to help the nurses care for the patients. The patient education is very, very, very important to me. These patients are scared. This is their life. You know, in medicine, we see it every day where we're used to taking care of one patient after another, one patient after another. But to them, this is a once-in-a-lifetime experience that they will never, ever repeat. So with the patient education, we've worked very hard to make comprehensive patient education books. When I started the job, this was 5 pages, and now it's up to 40 pages, which almost every department has had a say on what reaches the patient. So they get preoperative education where I meet with them, and this helps me be their advocate. Patients tell me special concerns they have that I can then relay to the operating room team. Such as if a patient feels that they're a hard stick, or if a patient feels they have issues with their neck and how they're positioned, or issues with their arm and how they're positioned during the surgery, I can be their advocate and relay that to the operating room team. It's education about their hospital stay, education about what they go through postoperatively and their discharge instructions. And I think it's very, very important that they receive all of that ahead of time. A schedule of how to prepare for surgery, what to expect during their hospital stay. It's very important for them to know what's normal and what's not normal. Little things like you may have a headache, you may have facial flushing, because guess what? Your blood supply is now returned to your cranium. So it's important for them to know that facial flushing is perfectly normal. Left shoulder pain, perfectly normal. That helps dispel their fears. And then letting them know the important postoperative reminders. And the biggest thing is what's not normal after surgery. They need to know that. Letting them know what tubes and drains they will wake up with in their body, what medications they'll be on and the potential side effects, what exercises they're supposed to do, and how they're supposed to eat after surgery. Most people in general respond well to structure. So providing the patients with this structure and knowledge ahead of time makes the whole rest of their hospital stay and recovery much smoother. As far as staff education goes, they need to know all that same information that the patients need to know, but even more. So I have the advantage when I teach nurses of having a 6-hour class. I don't have that same advantage with occupational therapy, pharmacy, nutrition. However, the patients will ask anyone and everyone questions when they're in the hospital. So it's important to make shorter, more condensed education for the whole rest of the staff and share that with them. You'd be surprised. Occupational therapy wants to know this. Nutrition wants to know this. Pharmacy wants to know this. And so making that information available to them really helps the patients. It prevents us from telling them the wrong information, because that's one of the worst things that can happen is another department tries to answer a question for a patient because they're a little nervous about how to answer it, and they don't give the patient the correct answer. That's one of the things that we absolutely want to avoid. And don't assume anyone knows anything. This is different than every other surgery. This is surgery that looks like almost nothing on the outside. They'll have 5 to 8 tiny little abdominal incisions. And so it's very important not to assume that anyone, no matter what their medical experience is, knows how complex this surgery is. So providing them with the considerations and complications in short bullet points really helps us watch out for the patient afterwards. And there's going to be a lot of misconceptions. Believe it or not, lots of patients ask me if a robot's doing their surgery. Showing them pictures of the surgeon at the robot helps dispel those fears. Letting them know that even though they're going in through the abdomen, this is a full chest surgery. They are not low acuity patients. They are high acuity patients who need the same care and consideration as a direct chest entry patient. And the one thing I cannot stress enough are surgical observations. Not just from nurses, but any department that wants to observe a surgery, let them observe a surgery. I take pharmacists to surgery. It better helps everyone understand the surgery, but also respect the complexities of what these patients are going through after surgery. One of our most experienced progressive care unit nurses took care of open heart patients, was a nurse a decade before I met her, walked out of surgery shocked. I loved what I saw. She walked out of surgery saying, I can't believe it. I can't believe it. He's all the way up here. Everything's all the way up here. Because no matter how many pictures I show them, no matter how much I tell them about what the surgery's like, there's nothing like seeing it in person to appreciate the complexity of the surgery, the skill of the surgeon, and what the patient goes through afterwards and all the potential complications they can face. Creating standardized protocols and pathways is very helpful without giving up control. So according to our government, the CDC, the number one way to create clinical quality improvements is with standardization of care so that no one department is doing anything different than our department. However, we cannot do that without giving up control, because at the end of the day, the surgeon has to have the ultimate say of what happens with his patients because they're all unique and different. So some quick examples of what I created for the pathways are information that gets emailed out to everyone on what happens in PACU, what are the standard imaging orders, what are the standard diet orders, what are our expectations for intubated patients, what are our expectations for ambulation and physical therapy, so that way if anyone comes in quickly from outside or who hasn't had extensive training with these patients knows what to follow. But if you'll notice, what's in red up top is always that you have to check with the surgical team. There's always a patient who's no matter how many zebras we have, there's always one that's an extra special zebra. So we always have to remind everybody to run it by the surgical team. Medications, providing a list of our standard medications. This is fantastic for the nurses to have because they double check everything for us. We don't even have to ask them to. They'll question, why didn't this patient get this dose of Lovenox? Why didn't this patient get that? They double check everything for us. Now, Dr. Ume did a great job of explaining the medications that the patients can get after surgery, but making a quick flow chart for the nurses. This is really helpful for those 3 a.m. phone calls. So when the nurse calls at 3 a.m. asking for something, they're looking at a guide saying, hey, we've tried everything, but that patient doesn't have Robaxin. Can you order the Robaxin? That makes the 3 a.m. phone call shorter. Creating a diet flow chart, creating an antibiotic flow chart. This all helps increase consistency, standardization, reduces variabilities, and increases patient outcomes. And this is one of my favorites, actually. This is about tubes and drains. This takes every major tube and drain that we have, that the patients get, and tells the nurses when to call and when not to call, what is normal and what's not normal, what amount of drainage do you need to tell the thoracic team about, and what color drainage do you need to tell the thoracic team about. This is very appreciated, knowing what's normal and what's not normal. As a nurse, especially if someone's a night shift nurse, that 3 a.m. phone call, you debate, do I make it, do I not make it? And now they know they have a little more freedom to say yes, they always want to be notified about this regardless of the time of day. Having worked night shift myself, this is very, very helpful. So when you start a program, Remember, every department needs training. You can't force training on a department, but most departments want it. So consider even pharmacy, PACU, ICU, PCU, radiology, home health care. Believe it or not, home health care agencies really like in-services, especially on equipment that the patient goes home with. Because like the Mini Atrium Express, the home version of the chest tube, may only have seen once in their career ever. So providing in-services to home health care is very helpful, and any ancillary department that wants it. And when the surgeon himself gives in-services, everyone really likes that. The nurse education program is very similar to what I just talked about. However, it has a little more structured format because the nurses spend most of the time of the day with the patient. They go to a new higher education class, whether they're a transfer from a different unit, a graduate nurse out of school, an experienced nurse for 10 years. If they're new to taking care of our patients, they go through this training. They also go through skills validation, and we want them to watch a surgery. So the skills validation, we call it checkoff. They have to complete that initially to take care of the patients, and then maintenance once a year in the key pieces of equipment that we use for our patients. We like establishing nursing teams. So initially, you have a core group of nurses who become the experts in taking care of the patients. Then we intentionally rotate the care to add nurse by nurse by nurse so that there are mentors on the floor all the time who feel like they are the experts of these patients. This creates a sustained culture of care for the patients. I also give one-on-one teaching with the nurses. When I round on them, I say, hey, did you know this dressing is overdue? Let me show you how to change the dressing. And again, as many surgical observations as we can do. Now, there is something, an idea that we kind of stole from Dr. Alabi and Dr. Ume. They were doing this in the intensive care unit, and it worked so well, we decided to extend it to the progressive care unit. The multidisciplinary rounds are amazing. What I've seen as a result of this is truly stakeholder buy-in from the nurses, a lot of creative ideas from the nurses who spend the majority of the day with the patients. So this is conducted daily. We meet in real time with real patients on the unit. As many departments as can go. Physicians, nurse practitioners, pharmacy, nutritions, therapies, care management, and we talk about that one individual patient. What are that one individual patient's needs? How close are they to discharge? What medications do they need? What concerns do they have? And what barriers are we having on not just as a program, but for that individual patient? It's an extremely wonderful model, and I highly encourage it. Our hospitalist, Dr. Dole, also does this with all the patients now. And my job in general is to look at the whole big picture and the continuum of care. The continuum of care from the time the patient even thinks about having surgery, through their hospital stay, till after surgery. And we really believe in a just culture. A just culture has to do with finding the root cause of problems, never blaming an individual, finding what's wrong with the process, and fixing the process. Okay, thank you.
Well, I am just amazed, Hannah. Thank you so much. I think that one of the important jobs for a society like SRS and other societies that are really making a change of culture in surgery is to understand that it's really not just about the technology. Over the last 20 years, we've seen so many programs fail because the surgeon gets excited about the new technology and introduces it into their practice, but all of the other pieces are missing. It's sort of like you make an electric car, like our next speaker loves, but then you don't have charging stations, so he's just standing on the street every day. So, and really, this is an important point, and I think someone like Hannah is an amazing person who makes this work. And I would say to every surgeon who's watching me right now, who is going to get into this world, you need everybody who has spoken today in your program, or it will not reach its potential. Now, it is a privilege to present or introduce our next speaker. Dr. Jay Redan is really a surgical giant. He is the chief of surgery at our hospital, Advent Celebration. He is also the president of the Florida chapter of American College of Surgeons. He is the surgeon's surgeon, And I think that it is important for someone with his stature to talk about where robotics fits into reoperations. Now, most importantly, he's got a first-class fellow in minimally invasive surgery who's the brains of the outfit, who's going to give a better presentation than him even. So we have two great people who are going to talk to us about what we should do with the failed operations of the past. Dr. Redan and Dr. Diaz.
Thank you very much, Dr. G, and the entire group here today has been fantastic. My little Dr. Fauci voice since I had my polyps removed, but I'm glad we're back giving talks again. Because this is CME lecture, I do consult with several companies that are related to this talk, however, none of which has any impact. Now, this is a very scary talk. It's like riding a crocodile. Going from open to robotic and laparoscopic takes, as we know, takes a team, and we have to get through these hurdles. Not all robotic surgery is this beautiful, elegant operation, as we can see. Because just as Dr. G mentioned, you don't want to see a lot of blood. You don't want to see holes in bowel. However, this is something that does happen, and we don't like to talk about. However, we are going to talk about that today. The other thing, as we mentioned before, these operations are not performed by R2-D2 and C3PO. They are performed still by humans. Even though I'd like to go from driverless cars to surgeonless robots, we're not quite there yet. And certainly we would not be here today without our great colleague, Dr. Rick Satava, who got us all interested in robotics almost 20 years ago now. The other thing I like to impress upon everyone, this is not about teaching an old dog a new trick. This is something that has to go through curricula, has to go through training, education, and we have to know what is the right operation for the right data set that we're presented with. We all learn things at different rates. We no longer do things, see one, do one, teach one. We have to practice, we have to rehearse, and we have to know what our own skill level is to assess what are we going to do as the surgeons to give the patient the best operation. So it is about training and simulation and practice. I'd like to introduce Dr. Gayla Diaz-Morales, our minimally invasive fellow, to go over some of the literature that's available now about redo hiatal hernia surgery. Dr. Diaz.
Hi, thank you for that introduction. We did a literature review about redo hiatal hernias, and what we could find is that there's still a few data about the redo surgeries on hiatal hernias. From all the studies that we review worldwide, we could get to the conclusion that around 10 to 30% of the patients who have a hiatal hernia repair will have recurrence. Most of the studies will show that the most common symptoms for recurrence are that the patients presents are dysphagia and GERD. But not every patient that will have a failed hiatal hernia surgery for the first time will end up having a redo surgery. Only about 11% of them will end up in the OR once again. But what we could find in all of these studies that they have in common is that the most common finding on a redo hiatal hernia surgery will be the slip of the fundoplication. That is the most common finding where we're looking in what we're failing and how we're gonna fix it. So many of the studies, of course, show the laparoscopic versus the open approach. Most of them will concentrate on the robotic areas and laparoscopic area. A few of them will talk about redos of open surgery. The ones that talk about it will mostly talk about it when they're doing a third or a fourth redo on a patient. And usually they talked about it more by performing a resection, a Roux-en-Y resection, because of the many redos that the patient had presented. Most of the studies will present their approaches, laparoscopic, either robotic. And what we could find from all the studies is that they will present to us how they're going to fix the problem. They will, one of them will say, well, they will redo the Nissen. Others will redo the hernia repair and redo the Nissen. Others will go into a toupee repair, changing from a Nissen to a toupee, and others will show the use of mesh. But even though they present all these data, it is all anecdotal data. Most of the studies are single-centered. They don't have enough numbers to present. And most of them will lose follow-up on this patient, and they show that they don't have enough power to show a statistical significance. So what we're dealing right now is why does this surgery is failing, and what do we do about it? Well, we need to take into consideration why did the surgery fail on the first time, and what are the different things that we can do for it not to fail a second time. How can we do this differently and consider all the options to make this mistake or failure happen again? And that's when we go into consider an open approach, which has not been talked about much in the literature, to really repair the failed first surgery that these patients are presenting.
Thanks. So as we know, as surgeons, we're all perfect. We never make any mistakes. How can my operation possibly fail? Well, unfortunately, sometimes that does happen. You know, even though we want to do it perfect the first time, things happen. Fortunately, I was able to get a few videos. Here's a video of hiatal hernia. As you can see, there's omentum stuck. The liver is a little bit in the way. They're up. You can see, obviously, the surgeon's up in the chest. And someone sent this to me to show what a great job they did. You know, and we're really not here to criticize how things look, but we can see this is a little bit different than what we saw from earlier talks. Here's someone trying to struggle. The diaphragm, and I don't even know where the right and left cruce is. I don't know. I see a little blood. I see a spleen. I don't see an esophagus. The picture is not an elegant picture. However, things like this still happen, and we do need to be aware of this. We do see situations. Here's a case recently that Dr. G and myself were involved with, a redo operation. This person really did not want a thoracotomy. So you know, we tried. Lots of adhesions as expected. The visualization is not perfect. But one thing we do know in our experience, as we get maybe, I'll have to say a little bit older, a little bit more experienced, a little wiser, I think is probably the best way to put it. When we can't identify the anatomic landmarks, when we can't identify where to go is safe, we have to choose a different modality. And what we are learning now is that training and education needs to be reevaluated. We still need to know how to do things open. We have to know when is a good time to use the robot, which certainly is clearly the majority of the time. However, the harder question is when not to use the robot. And that's really something we still need to think about. There are several points that were very clearly made today, that surgical skill is important, the team is important, the pre and post-op care is important, the medical management is important, the ICU care is important. And we have to take many of these factors into effect when we take care of our patients, starting with training and education. One of the great articles that's come out recently, this is from Dr. Satava from us here in the Nicholson Center, is identifying a proficiency-based progressive training for the surgeons and consistently meeting a high level of skill. I have a great example. I know Dr. Diaz said, congratulated her. She passed her boards. She passed her written. She passed her her oral exam and say she got an 80. 80 is a great passing grade. So that means only 1 out of 5 times you're going to make a mistake now. That is not acceptable. However, that's how we score everyone. But when it comes to our patients, as we saw on previous slides, we have to be perfect every time. We need to make sure our psychomotor skills are good. So all these things go into development of a great program. And certainly, I encourage everyone to visit Fundamentals Robotic Surgery. And certainly, we like to make sure everyone is trained properly by practicing these skills in the lab. So in this, we'll go back as we do questions and answer. There's some other videos we can show, and I'd like to show some open procedures as well. So we will continue with this momentarily. And I'd like everyone to come forward. For some of our questions and answers.
Thank you, Jay, and Dr. Diaz. Really a nice presentation about the fact that to make sure that the robot succeeds, you got to know when to use it and when not to use it. So, and I do agree, 80% is fantastic. We're proud of Dr. Diaz, but she needs many more years so that, and it's really the days of having new surgeons kind of learn as they go. And I don't want to say learn from patient mistakes, but this is unfortunately the culture of surgery. We are changing the culture of surgery, hopefully by understanding that mentorship and parenting of young surgeons is very, very important because every patient expects perfect results. So we have first of all, congratulations to our speakers because we are, I think, like an hour early, so this is fantastic. They say if you know the answers, it doesn't take you long to take the test. And I think these guys all know the answers, so that's great. Secondly, we're going to maybe for the next half hour have a panel discussion. Everyone's around the table. We're going to let Dr. Redan moderate this session, and there have been questions from the audience. We appreciate their participation, and I think that we can shed some light on some of the questions. Thank you, everyone, and Dr. Redan.
Sure, thanks. As we noticed, there's some recent publications. Certainly, SAGES has redone their guidelines for surgery, and in that publication, reduced via thoracic approach was not mentioned. I know we know in our recent series we had 183 patients with 5-year follow-up, redo all by thoracotomy, and they do great. Probably, 92% come from outside the area. What are your thoughts on what have we missed on the redos, on why people are not offered a thoracic approach?
Great question. It's interesting. Surgeons sometimes get a bad rap, because it seems like if things don't go right, it's our fault and all these things. But sometimes surgeons are pressed by the social pressures around them. I find that surgeons think that it's like it's totally taboo to tell a patient this cannot be done by minimally invasive surgery. I mean, here we are a center, probably do more robotic surgery than any single center in the world. For the patient to come here and for me to say, I don't think this should be done with the robot, that takes courage. And I think that courage is the key for the surgeons to know what they can do and what they can't do. And as we get more experience, we understand that the only thing that matters is the perfection of the surgery. Not how you did it, they never remember that, but they will remember the problems. When we ask our patients who get redo surgery by a thoracotomy, which is a big deal, I just told you all the problems, but in that case, the surgery is more important than the thoracotomy. At 6 months, those patients will send us emails and saying, I feel great, I don't care about the thoracotomy. And not only do they do that, they tell other people through social media and unbelievable things that this is the way to go because they're feeling great. So when you have that, you know that you're kind of getting onto the right track. So I believe that this is a reconstructive surgery. Dr. Diaz spoke about taking a Nissen, turning it into a toupee. That's a euphemism. What that means is you just cut 2 stitches and turn the Nissen into a toupee. That's not surgery. And if you ask surgeons who do this surgery, how often do you take everything down and reconstruct it? It is less than maybe 3% of the time. So the surgeon doesn't want to hurt the patient. There is a lot of scarring, as we know, in that hiatus. Dr. Alabi showed you what that does to the heart and everything. Well, now you're trying to peel this stuff off the aorta, the vena cava, the atrium. You're not going to do it, or you're going to really hurt somebody. So the surgeon kind of tiptoes around, does a few little things, and then they say this was redo. That's why redo surgery is really a euphemism. It fails because it never was redo. It's the original problem persisting. We believe, Dr. Redan and I are partners in this, that you should take it all down and reconstruct it and go back to the way the giants describe it. So redo surgery in our hands has had superb results because we don't take any prisoners, and we go back to Mr. Belzi. Because Mr. Belzi, if you look at his data, 85 to 90% success rate is amazing with all of the issues of the 40s and 50s, anesthesia, et cetera. So the thing is, surgical giants knew the answer. We go back to that. So that's our feeling, and I think that really the other piece of this is if you speak to some of the great robotic surgeons who do this, such as Ivo Broders from the Netherlands, some of these really giants of the present time, they would say redo surgery is one of the toughest, if not the toughest, operation on the face of the earth when you're doing this, which means there are problems. Anyway, thank you.
No, thanks. The question for Dr. Ube and Dr. Labi. We talked a lot about post-op care and some about pre-op care. How do you prehabilitate your patients before hiatal hernia surgery? How do you get them, we used to try to get people to lose weight, which we understand maybe from the physiology is a little difficult. How do you get them to control their diabetes? And how do you get them to control some of their lung issues so to avoid some of the issues that you're talking about in post-op care?
So, I think it's very, very imperative that when we see patients in the preoperative area, from the pulmonary standpoint, obviously, if they have, any underlying respiratory issue, we make sure that it's well optimized before we clear them to go for a surgical procedure. And sometimes there might be people that they've never been diagnosed with lung disease, and that might be the first time. You do a PFT or you do a chest X-ray and it looks abnormal. So we just pick up the phone and call our surgical colleague and say, hey, we know this patient is scheduled for this day, but we need to optimize them because when they go in with their best lung, the chances of going through the entire process, with a good outcome is better. So, and the patient understands it. They're doing an elective procedure. There's no urgency to it. Sometimes there's issue of pressure on us because some of these patients, they come from far away and they're staying in hotels and they've already been scheduled for, their procedure on a particular day. And it all depends, if it's, if somebody comes from far away and they're smoking, we tell them to quit smoking if they can. But if this is somebody that is living locally, we can always postpone the procedure. It's very important to make sure that they don't have any ongoing respiratory infection, because that's the last thing you want. You subject them for surgery with the double lumen endotracheal tube. They have some bacteria in their airway. The chances of developing postoperative pneumonia is very high. So, we're just very proactive, optimize lung functions. Obviously, they won't lose weight within a short period of time. Majority of time before they see us, I think they've already done that. Before they see us, they've made sure that if they have diabetes, their sugar is well controlled so that they don't come in with risks of postoperative infection also. So, those are the things that, we try to do ahead of time. before providing surgical clearance?
Yeah, I mean, the difficult part really is, like he kind of clearly mentioned, a lot of patients come from out of state, so you really have limited time with them for obvious reasons. So to me, I kind of see the pre-operative valve as being able to optimize the ones you can, specifically find any kind of underlying lung issues that you may kind of affect by providing bronchodilatory therapy, trying to let them know that even one day of stopping smoking has a benefit. The longer you can quit smoking, yes, the more beneficial it's going to be. Of course, losing weight is a little bit more long-term and kind of rather difficult to address in a short-term pre-op visit. And if they have uncontrolled diabetes, you're aware of it, and then obviously following surgery or in the immediate post-op period, you're able to intensify the therapy to get the blood sugar under control to help with the wound healing and avoid further complications. The key is just trying to kind of individualize what you do for each patient based on their medical issues as well as the social environment that you have to kind of operate under.
Dr. G.
Thank you. Actually, just a comment on the weight loss. You know, the concept of losing weight before the surgery came because of the laparoscopic technology, that you just can't work in that space. That really doesn't seem to apply to robotics. And many of these people, as we've found, cannot lose weight because of the cardiovascular and so forth issues. So weight loss is not that important, I think, anymore. The other interesting thing, and I'm kind of going way out on the limb on this, but it's very interesting that there are certain patients who have had true reconstruction of the hiatus instead of a bariatric operation, and with the cardiovascular changes that occur to their metabolism and everything, have lost weight almost equivalent to having some sort of bariatric surgery. So it seems that the approaching the hiatal area before you put in someone for whatever bariatric procedure may be something that we're going to look at in the future. Having said that, I want to introduce my colleague, Dr. Dole, who is significant in the care of our patients. Dr. Dole dropped by, which is great, so he's joined us. Dr. Dole, tell us what your thoughts are about the preoperative workup of these patients before they come to us, please.
So, I mean, I don't generally see a lot of these patients preoperatively. I think, you know, they are seen by our pulmonary colleagues, but we do get some patients that, you know, are not, you know, Dr. G patients yet, right? And we see a ton of these. I mean, you guys, all of you guys spoke very well about, you know, how common these are, right? And so we're finding a lot of these patients that come in for chest pain and, you know, respiratory issues, and then we kind of start the workup in the hospital a lot of times, and then, you know, refer them out to our GI colleagues and such to finish the workup, and then, you know, eventually get referred for their surgical correction if indicated. So, but yeah, we are seeing, and you know, since this program has started here, you know, I think a lot of us are much more aware of that now, and key into that. So it's been eye-opening for a lot of us.
You normally would, like, in these patients, get a cardiac test? Do you think it's an indication, like a stress
Absolutely,
test?
absolutely, yeah. So I think part of the preoperative assessment that we get is, you know, we have our cardiology colleagues see the patients, evaluate for any type of ischemia. Many of these patients do have some sort of underlying coronary disease, and that's got to be obviously notified earlier. As Dr. Alabi pointed out, you know, a lot of times we can postpone these surgeries if needed. So if they need some revascularization done, you know, that needs to be done up front to put our patients in the best position to succeed. We check for, you know, we check their lower extremities for clots. That's an important thing to know as well pre-op, and some of them may need IVC filters preoperatively. So these are things that we have to do to optimize, you know, our patients and put them in the best position to succeed.
Thank you very much.
Yeah.
Thank you.
You have kind of a combo question on when do you think, or how do you know if it's best to treat the anatomy of the problem versus the symptoms and then the physiologic outcomes of some of the anatomy? And is there any publications talking about the cardiac and pulmonary effects? Because this is kind of new to, I think, a lot of us. It's almost a paradigm shift, not quite as and different going from open to laparoscopic surgery, what we did, and we were through that, almost 30 years ago. But the thought process involved with our medical colleagues on how to rethink about hiatal hernias and the cardiac pulmonary effects versus the GERD effects, which we mentioned should probably be treated significantly different.
So I think, the need, both of them needs to be addressed, right? So if you don't treat the reflux, there is, the complication of the Barrett and risks of having esophageal cancer and all kinds of other stuff that might happen to the patient. But most importantly, is from the pulmonary and cardiac standpoint, addressing the anatomical part is very, very important also, right? So then if you look at it from the standpoint of patients like the pulmonary fibrosis patient with the risks of silent reflux that might, contribute to the progression of the disease, treating the reflux is equally as important as taking care of the hiatal hernia. So I just think if somebody's going to fix it, they should just address both.
So a little follow-up question. Many physicians continue to keep people on proton pump inhibitors and post-procedure. What are your thoughts on that?
Yeah, I mean, that's a difficult one to kind of answer because, again, it all depends on what their preoperative complaints were. Okay. If you are able to clearly define what the preoperative complaints are, I personally will feel comfortable to stop the treatment and then reassess in a few weeks or months to see exactly whether it's been properly addressed solely by the surgical therapy or do you still need some form of reflux therapy going down the road. Again, just using medication by itself doesn't really control reflux that well. If you kind of add all the other life-changing lifestyle modifications like timing of your meals and avoiding caffeine and head of the bed elevated, if you combine them all, yes, you may be able to just stop the medications. But again, all depends on what the symptoms are. If they completely resolve with just the surgery, then there's no point staying on treatment.
Maybe I can comment on this. Dr. Atik had to leave, but I'll sort of speak for the gastroenterologist or the esophagologist. First of all, as you saw, very important point, he did not do a pH test on these patients. That's a major lesson for our audience. Patients with hiatal hernias do not need pH testing. pH testing, some studies show that the pH testing will be positive, not from gastroesophageal reflux of acid, but when they have bacterial overgrowth of the esophagus from the bacteria producing acid. So the issue really is, as he told you, no pH testing because it doesn't mean anything in these patients. That is taking us away from GERD. We're understanding that there is this condition of esophageal reflux that we kind of talk as GERD, but it's really not. These patients have organ failure, and this is all new kinds of thinking that we're getting into. It takes me back to my training in CT surgery because, he told us if the esophagus is not working, do not do anything. That's the same dictum as if someone has heart failure from aortic valve disease and you replace the valve. Not going to work. The organ's done. So it's important to come to it earlier. That's one thing. Second thing is some motility issues are okay because that means the organ has been affected by this obstruction and dilated and it's not working. So that's why we put them on promotility. This is like a wide open field we're getting into, and we're finding that really the antacid medications of whatever, as Dr. Ume said, don't make much change. Sure, if I have esophagitis and I have less acid, it won't hurt as much, but it's not going to fix the problem. And now the new thinking is this may be blood flow. He even said that in his talk. This may be a blood flow issue, and it may be an inflammatory process that we need to come at it from a different direction than acid, because all acid suppression in these patients fails. It's not really doing much. So interesting questions.
Dr. Dole, you have anything to add to that?
Not really. I had a kind of a follow-up question, actually, if you don't mind. So we talk a little bit about the motility issues that these patients have, and I was wondering if you can comment, and maybe Dr. Atik, I wish he was here to comment on this too, on the timing of what that looks like for patients. You know, I know our patients sometimes, you know, will suffer from these effects for a while afterwards.
It's a very good question, and it takes me back to, you know, to cardiac surgery again, you know? You end up, I remember days when you would put somebody on pump, you would do a repair of the mitral valve, and they just won't come off pump, and you have to put a balloon in them. But after a while, they can get separated, and I'm not trying to get into that world, but the point is, the organ needs a bridge. And this is exactly the same thing in our experience. You know, we are fortunate to have such a large experience. So we see that these patients for many months after surgery will have motility issues. They start with some, and I think the surgery makes it worse because now we're giving them obstruction against this organ that's already having trouble. But then it gets better as we put them on the for motility agents, and time heals the esophagus. So when we follow these patients, it seems like somewhere from 6 months to a year, the motility gets back to normal, or really significantly back to what we consider normal, so they don't have symptoms. The other reason of the motility is the surgery. You saw, we are devascularizing that esophagus with all that dissection. No one thinks about that, right? It doesn't die because we're learning about the blood flow of the esophagus is not what we used to think it was. But without a doubt, there is an ischemic component to all that dissection. And that ischemia has to resolve as new blood vessels come in and the organ starts to. So it's really the same as a heart recovering after repairing a valve and needing some help.
Good.
Dr. Alabi, do you have any thoughts about that?
No, I think I love the analogy of the, just post-cardiac surgery, whereby the EF might be very low immediately after the valve is replaced, and then with time, we wean them off the balloon pump and the patient gets better. So I think that concept maybe will make a lot of sense, if somebody can have a correlate between cardiac recovery compared to esophageal recovery.
Yeah. And again, the surgery itself also has some vagal dysfunction too. By pulling the vagus nerve, you end up with some kind of vagal neuropraxia that will take time to resolve as well. And that would also affect the impact on the esophageal gastric function.
Yes.
Or to put in the surgeon terms, the stomach gets really mad and it needs time to wake up.
That's true.
So try to keep things simple. So, a couple questions for you.
Mm-hmm.
Why do you put the laparoscopic trocars in first and then put the robot trocars through the laparoscopic trocars?
So initially we need to gain access to get the robot's arm in. So we put the laparoscopic trocars first, and then we place the robot trocars, arm after that. It's easier that way, and it's smoother with the surgery.
Okay, very good. And then another question that maybe combine this with Hannah. How do you get the OR director to allow you to have a dedicated OR team in the OR? That's usually very difficult, and a lot of our colleagues throughout the world that are watching us today, hospitals.
Yeah, that was not easy. That took a lot of work for years before we could get to that point, and I think Hannah can add to that too.
Well, the best piece of advice I could give is if you are starting a program at a new facility or a new place, have a list of demands going in. It's easier to get them to promise you something when you're starting than ask for it later. But if you're already existing in a facility, it's presenting them with research on the benefits of teams and then asking until you get what you want. And don't just have one person ask. Don't just have Dr. Garagozlu ask. Have someone like me ask. Have someone like you ask. The more people that hear it, the better. And don't give up. Don't stop asking. Don't say, oh, it's just this place. That's not good enough. That will never be good enough for your program or your patients. And I do think a lot of times it's better if it's not coming directly from the surgeon, because we just want him focused on surgeries and good outcomes and let someone else fight the battles for you.
Him or her when referring to surgeons.
Him or her.
I work with one.
Yeah,
so.
if I may comment, this is a major problem for surgeons. This audience members are having PVCs as we're talking about this, because the culture of surgery is broken. Let us say it right out there on the web. And it is a culture that comes from the 1940s and 50s, and nothing has changed. And frankly, if our patients knew how broken it was, they would never come to surgery. And that, I mean that. The surgery needs a culture change, and I don't mean that in a bad way. It's a good thing. We're changing it, just like with everything else. But everyone thinks, I come from the Middle East, or my ancestry is Middle Eastern, so in the Middle East, everything is written. You know, everything is like out of your control and the reason we all came to America is nothing is written. This is what I love about this country. And so you got to understand that it's through work and great colleagues and results, and it's like a jungle. In a jungle, you don't just sit there and think all the fights are over, because someone's going to eat you as you're thinking that, right? So you have to keep fighting. Dr. Alavi's laughing because he agrees, and that's what we have to do. But in a jungle, it's a lot easier if you're surrounded by a bunch of people with a lot of guns in their hands, and that's what we have, and that's important. So don't give up, but I think that a robot team and a robot thoracic surgery team are different things. The thoracic surgery team needs to do robotics. You cannot have a robotic team in the OR, which is the majority of places, who do GYN one-day thoracic. No, that's a formula for disaster. And then you need agents like Hannah, who truly drive this every day in the system, in the hospital, because we are changing the culture. It's a big ship we're turning, but it will turn, and that's the message.
Can I revisit the one topic I brought up before, and that's surgical observations?
Sure.
Don't assume your chief medical officer, CEO, or chief nursing officer really understand the surgeries or the complexities of what goes on in the operating room. I mean, I can't pretend that I do, because I'm not there every day. I've watched every surgery there is to watch, but only one or two, and I don't think there's anything as valuable as watching a surgery. When anyone I take goes to watch a surgery who's not from the operating room team, no matter who they are, nursing, administration, pharmacy, nutrition, they all walk out in awe. They cannot fully appreciate the surgery unless they see it themselves. So if you want the CEO to listen to you, take him or her to watch a surgery and explain the surgery to them. And, as much as you can speak during the surgery, maybe some of it waits till after, that's when you say, see, that's why I need this specialized person for this, or I need this specialized person for that. But there is no substitute for actually seeing a live surgery, I don't think.
Oh, thanks. And I guess along similar lines, how do you work with pharmacy, getting administration to give allowing us to use the expensive post-op pain medicines like Precedex and IV acetaminophen?
Again, when it comes to quote-unquote expensive post-op medications, all it takes is one episode of 2-week prolonged ILS on TPN to pay for a whole 6 months of Precedex. And if you think of all the side effects that you can save yourself in terms of having to resort to TPN because you can't feed the patient, prolonged ventilatory stay because you can't win them out the ventilator, and pneumonias with prolonged stay because they can't breathe on opiates, and of course we all know what opiates do in terms of delirium. So once you can line up all the possible side effects of all these drugs, then it's a little bit easier to realize that yes, they may look expensive, but in the long run, is a much better path to follow. Yeah. Again, we fought out this battle before we even got to thoracic, so it was a little bit easier to just, kind of transfer the same plan, the same management to thoracic surgery, but clearly using those drugs upfront minimizes a whole lot of post-operative complications.
Good question for Dr. G. How do you deal with a large left lobe of the liver? That sometimes
It
obliterates
doesn't
it,
matter, you know,
basically.
you can have large or small. The issue really is that we have learned to use like is it Nathanson? Is that the retractor? You know, yeah, it's no good. The Nathanson retractor, in my view, or retractors like that are from a different era. They don't put enough pressure on the liver. We actually will not divide the connection of the left lobe to the diaphragm and use the elevation, as Amin showed, of the left lobe of the liver as a way of elevating the hiatus. It's like putting the air in a tent. It opens it up so we can go in there. So it actually helps us, and Nathansons and such things don't do that. If you do too much pressure, and whoever's asking knows, now you're going to be dealing with liver holes. And the key to this surgery is, just like any good surgery, go to where you are, do your thing, and get out. Don't make new operations with livers and this and that. So the retractor we showed you is like a piece of cloth with a metal frame underneath that opens, and it puts a lot of pressure, but it is a distributed pressure rather than one point. And it's like a regular shoe versus the stiletto shoe, you know? The Nathan's is a stiletto. And so that helps us with exposure. It's actually the third assistant. And then you don't have, we've learned this, don't have somebody hold it. They're going to let it down. So once you set it up, you set it up. And that holder that we showed is the key. And I think that's the thing. So there is no left lobe. But the main point is don't dissect the lobe off the diaphragm, or it's going to be flopping in your face. Use it to your advantage.
Okay, great. Quick question on, I guess probably back to Amin and Hannah. You mentioned a lot of people around needed, you know, the robot, the nurses, or intensivists, the equipment. How would you suggest a quote unquote smaller hospital be able to perform this kind of surgery with possibly limited resources? Do you think they're able to do it, or do you think they should refer them out, or maybe Dr. G too?
Limited resources, wow. So our team is, in our team there's 2 nurses, 2 circulators, and 2 assistants, and 1 scrub nurse. Everybody is working. Nobody is, like when the first assistant is holding the kidneys and stuff, the second assistant is doing another thing, and then the scrub nurse is also doing a different part. So I think it is necessary to have every single member in there. Absolutely everybody.
So which patients do you think should be referred to a tertiary care center or not? And have any thoughts on that?
Probably.
Or maybe anybody in the panel?
It's not about the number of people that are on your team. It's about having the right people on your team. So, you know, Dr. Garagozlu gave training to some of the ICU nurses when the program started, and what he said was amazing and also very humble, is he said, I can do the best surgery in the world, but if they don't get proper care the second they leave my operating room, the surgery will not be a success. So even if the surgery is a success, if the postoperative care is not a success, then nothing else will be. So having a Dr. Alabi and a Dr. Ume on board who worked really hard to take a small community hospital, because yes, the hospital we are at is growing rapidly and has so many different surgical services, but it started out as a very small community hospital. And our ICU, our intensive care unit, was basically built by Dr. Alabi and Dr. Ume. They held the multidisciplinary rounds daily on every patient with those ICU nurses. And that is what made our ICU and ICU capable of taking care of these patients. So that would be the first place I start if you're a small community hospital, is having ICU intensivists who work directly with the nurses, who build those nurses up. And the equipment afterwards, postoperatively, isn't special. the patients get a chest tube, they get a nasal gastric tube, they get a urine catheter. The redo patients get an on-Q. Equipment-wise, postoperatively, it's not special. But what was special about our hospital was Dr. Alabi and Dr. Ume. So having those key people, if your hospital doesn't have them, get them. Have them start working with those ICU nurses, do those daily multidisciplinary rounds where pharmacy goes, they run it. They have the nurse speak, and the nurse presents on the patient. That's important because that builds ownership from the nurse. It elevates them to really understand what's going on with the patient. That's exactly where I'd start. That one position.
For our surgical colleague who asked that, it's really important to know that you should walk before you run. And honestly, as our program has matured, my courage has increased and so forth. So it's important, again, I'll use the analogy of the nuclear navy. The reason the nuclear navy worked and still works, and for those who don't know, the nuclear navy won the Cold War. It was not the ICBMs, because it was the only stealth machine that could not be seen by the enemy, was the fact that it did not have a single accident. The Russian or the Soviet Navy had many accidents. Those are the ones we knew about. God knows how many really happened. But the issue is that when Admiral Hyman Rickover started this, his number one rule was no accidents. Never. And that means you slowly get into it, one submarine and another submarine and so forth. And he trained every member of the nuclear Navy. And that's really the message to everyone. This is not, don't get a robot, put it into these huge hiatal hernia and think this is going to work. It's going to be a disaster. And don't use the robot if you think that you can do it without. Better. So step by step by step, I think you got to get in. So I would say it doesn't matter how big or small the hospital is. The surgeon has to be comfortable with. And the other thing is the drills. I mean, our operating room that's run by Amin is truly a military machine. I always say, if a SEAL team is sent to kill somebody and they do it perfectly, an operating room team needs to be better than a SEAL team. We're saving lives. And that's what they do. So if I get into trouble in the chest, seconds, because all of a sudden you're swimming in blood and you don't see anything, and you can't open somebody's chest, they're on their back. What do we do? So it's about prevention. So whoever is thinking about this needs to slowly get their feet wet. And then the second thing is know every possible thing that can happen should have drills about what's going to happen. And that's how you stay out of trouble. And prevention rather than fix.
Can't agree with that more. That's we teach that every day, from a quote unquote simple gallbladder to a simple hernia to a redo this in or esophageal gastrectomy. Absolutely. A couple more questions. One about the definition of a giant hiatal hernia. I know Dr. Hegan fortunately has left. We've heard 30%. We've heard 5%. Do all hiatal hernias need to get fixed? What are your thoughts?
I'll turn it back to him because he basically just blasted my thought process of what I thought was large or small. I had to basically just pass over on that. I'll defer to my surgical colleagues on that, yeah.
I'll talk for Dr. Atik. We're learning that these definitions are old. And, it's like, who said 30%? Where does this come from? It's an interesting thing, again, about something is being written. We think that this God said 30%, so we cannot question this. But we can question it. And, 30% has been used because that was sort of the limit for the surgeons. So they said anything more than 30% is a giant one. That means it's a tough case. Anything lesser is, really, that's what it is. You know that. So what, 30%? No. So the main thing is, I think that the reason we actually put giant hiatal hernia for this conference is to erase that word rather than to bring it. A hiatal hernia it's either pregnant or you're not. How big it is, it doesn't matter. And really, that's the thing. So either you're stage 1 disease or you're stage 2 disease. And I think that helps us, and as you heard from Dr. Atik. Dr. Atik believes and I think the number is still 2 to 3 centimeters or higher on endoscopy should have reconstructive surgery rather than reflux surgery. Less than 2 centimeters is a medical disease. You may, if it's refractory to therapy, et cetera, give them some sort of an operation, but those patients are not that. And if you do it that way, then the results are better rather than one size fits all, which is what we're doing.
But what about if you make the distinction of the demarcation based on just the size only? You know, what about somebody with completely asymptomatic, you know, like 5 cm hiatal hernia? How do we justify, you know, intervention? They have no symptoms at all. This was just an incidental finding on the X-ray.
Well, that's a very good question. To be honest, I don't know the answer, but I would tell you this. As you saw, you see more the more you look. I would say that that's a very unusual situation, just like the stuff you described.
Yeah.
Once it comes, I think it's all in the eye of the beholder, the definition of symptomatic versus asymptomatic. The more we understand about this disease, you know, if you're a gastroenterologist, symptomatic is one thing. If you're a pulmonologist, is one thing, you know, and so forth. So I really think it would be unusual to have a 5 centimeter nose. One of the things that's most impressive to me, I swear to God, and this is important for our colleagues, when the patients come to see me from outside some other place, not our own group, they will come for reflux and the fact that, you know, they have GERD. Then we'll sit and talk about all the various possible symptoms, and they invariably start getting upset. Why didn't my doctor say something about this? I have been having hoarseness for all my life. I've been coughing. I've been fatigued. All of a sudden, because it's all in the eye of the beholder, and at the end, many of them actually cry because they find that, right? Hannah is shaking her. They cry because they feel vindicated. They've been telling their doctors, I got all these other problems, and the doctor's like, well, you don't have reflux. You're okay, you see? So I think that maybe Hannah can comment on that, but it's really how you're defining symptoms.
I mean, I think, you know, because of the volume that you do, or that, you know, we do at the hospital, maybe it might be time to put together a very comprehensive, validated questionnaire to really capture, you know, the full symptoms of this patient, so that, you know, hopefully, maybe with time, we might be able to create a questionnaire so that, you know, when a patient shows up at the doctor's office and you find a hiatal hernia, you have some set of questions. Because an average person just, oh, do you have reflux? You know, you have no reflux. Okay, we just watch it, or, you know, when your food gets stuck one day, call us. And that's about it. And then the patient tells you, oh, you know, I've had it there. My doctor, the first time they told me was 10 years ago. You know, so I think this is going to open up. There's so much we're learning from these. I mean, I've learned so much, you know, within the last 5 years myself.
Well, there's definitely a reason why antacid medication, proton pump inhibitors, are the #1 prescribed drug in the country. So, Hannah?
Oh, no, I was just like, Dr. Lobby, that's our next project.
Yeah, I think we should do it. Yeah,
Absolutely.
I think so. I think so, yeah.
Dr. Garagoslu gets referrals from unexpected places. So yes, obviously gastroenterologist, he gets referrals from them. He gets referrals from pulmonologists, but also hematologists and cardiologists. So I think that there are a lot of different areas where the primary care physicians are who we need to reach and get to, because these patients, you know, they get bone marrow biopsies. They have these huge cardiac workups. And basically the problem was the hiatal hernia. And it's just something that, you know, I didn't know about myself until I worked with Dr. Garagoslu. I used to be a science teacher. I taught biology. I've been through nursing school, and I didn't begin to understand this disease or the complexity of symptoms until I worked with Dr. Garagoslu and saw patient after patient after patient crying after they see him because they say, somebody finally listened to me. Somebody finally was able to tell me what's wrong, because so many of these patients have been suffering for not years, but decades with their family, their friends, even physicians saying, well, you've gained weight, you're older, you're tired, this is to be expected. And then to see these patients, like 6 months after surgery, how happy so many of them are is really amazing.
I have a question for Dr. Alavi, since really he opened the door on all the cardiac issues. No, really. It's all about diastolic dysfunction, right? Yeah. Do you think we should do better on testing in terms, because the systolic we're good at, diastolic kind of gets lost. But in these patients, what are your thoughts about that?
In general, diastolic heart failure is difficult to diagnose, even for the cardiologist. And so, but again, we can engage a very smart cardiologist, and brainstorm with them as to the best way to evaluate for it. But I think I was just amazed when I started looking into some of the cardiac complications, and some of these things have been in the literature since the 50s. And I was wondering, how come I'm just reading them now? And I can tell you that a lot of my cardiology colleagues are still not aware of this. You see people with AFib and they will shock them. They send them to us for sleep apnea. Everybody knows the association. Say, oh, you have sleep apnea. We need to take care of that. And then, a young person, no high blood pressure, nothing. And then they put them on antiarrhythmic drugs. And there's hiatal hernia there compressing on the left atrium, and nobody knows about it. And I didn't know about it too, so I'm not even going to lie about it. So I just think there's a lot of opportunity to study this a little bit more. There's a lot of opportunity to, engage our cardiology colleagues. This kind of talk, we should have invited them. There should be a team of hematologists, cardiologists present at this meeting, because I think there's just a lot of things that everybody can learn and then come together. Hopefully we can come up with some better questionnaire to be able to capture the symptoms that this patient, present with, so that we can do a thorough evaluation when we see them.
Thank you. Thank you.
Okay.
One question for Dr. Diaz. As a newly board-certified surgeon, how do you think is the best way to learn how to do hiatal hernia surgery? Simple question. What sort of training and education pathway you think is best from a surgeon's point of view?
Well, I don't think there's just one way to learn it. I think you should be, the more you're exposed to the different approaches that people do, you will learn, and you will actually see the key steps that you will need to do to reach a proper repair. By coming here, I saw the approach and the dissection that we talk about, that the robot allows you to do in a so narrow space. But it was just by looking at different techniques from Dr. G and Dr. Redan that I actually, by seeing them perform these surgeries, I have learned what I can do and what I have to be careful with, and which steps are the key steps to make a perfect surgery on this. It is a complex training. You finish general surgery, and then you get exposed to all these robotics and open approaches. Many people won't get even exposure to open approaches. But I think the key will be to see, the more you see, the more you learn, and the more careful you are about the key steps that you need to do, and to learn which is the better way to do it, and when you have to do it, either open or laparoscopic, or which is your best technique that you can offer the better repair to this patient. So.
Right, and certainly the most important way is to do it right the first time, clear it clearly, and as we mentioned before, open laparoscopic or robot, a couple months, as long as they're fixed, they're fixed. Obviously, there's significant benefit to have it performed using minimally invasive technology, but there is definitely a learning curve. Everybody learns at a different rate, as we mentioned. Watching experienced surgeons do it is obviously very good, but actually also having experienced surgeons watch the student do it is equally important to make sure that we have a good feedback loop. And I think that's part of our continued training and education that we do very well here. So.
I'm going to actually follow up with what you said, because this is a little bit, obviously, our audience are surgeons. Jay would agree. You know, we really are sort of have done this for a few years and made many mistakes and learned through it. But I got to tell you, when I was choosing surgical programs, I really was mistaken to think that the typical surgical program was the way to learn surgery. My father, who was a surgeon, was a lot smarter than me, and he insisted that I go and learn surgery at the Mayo Clinic because they did surgery differently than anybody in the world. And they did the apprenticeship model. And to be honest, I hated him for a long time for making me do that. And I was very upset because at the Mayo Clinic, they believe in step by step by step. They will not say, because you're a second-year resident, you do a gallbladder, et cetera, the usual garbage we say in surgery, which is passé. It is you perfect one piece. Like if you're going to make something as an artist, as an apprentice, you learn certain things, then you learn the next thing, and you put it together. That way, every time you make whatever it is you're making is perfect, right? In surgery, we are mistaken to think that I can put you on a robot and say, go ahead, Dr. Diaz, and then you make a mistake, then I yell at you, and then take it away from you, and everybody's upset, and things don't go well. That's how surgery is, right? I mean, let's be honest. That's the wrong way. The way is parenting. That's not how I teach my daughter to do things, right? And a good parent will step by step get them to where, and we need to change the culture of surgery. The robot is making us do this because I can't control you anymore, right?
Yeah.
In an open case, I can just hold your hand or do something. But in this one, I have no control. And the assistant console doesn't help because you got this thing, you know? I'm like, so the issue is the only way we can save the patients from problems and teach you, it has to be step by step, and then you put the whole puzzle together. And I think that it is really important for the surgeons to rethink how we do it. And that's my 2 cents on that one.
That's perfect way to.
As a final thing, I would say, since we're finishing, I want to invite our audience members, anyone who wants to come visit our institution and learn from these great people, they're welcome to. This happens a lot here, and an open invitation to all our colleagues out there in the world. Thank you very much.
Thank you.
Thank you.
Thanks. Very good.
Thank you.
Perfect.
Have a good day.
Thank you.
Thank you.
Perfect. Thank you, guys.
Thank you.
Thank you.
Quick question. So sometimes when you